Welcome everybody to the Bellies to Babies Foundation event sponsoring Midwifery International. I wanted to let you know that we will begin our keynote speech in about 6 minutes. So if any of your friends are perusing in the atrium area, it's time to tell them to come on in and have a seat. Ms. Hensegoer will be speaking in about 6 minutes. Thank you so much for coming.
Thank you so much, everyone, for coming, and welcome to Bellies to Babies 2012 Benefit for Midwife International. We're very excited today to have our keynote presenter, Hensegoer. She's known all over the world for her work, and we're very proud to have her here today. She will be presenting Preventing the Preventable C-Section. Sorry. Sorry about that. This is for the professionals. This is the Optimal Care. She'll be talking about her book, Optimal Care, and definitely worth hearing. If I can step away from the event, I definitely want to hear it myself. So welcome her. Give her a warm welcome. So, who have I got here? Doulas, midwives, student midwives, childbirth educators, nurses. So cool. Nursing students, doctors. Yay! What? A doctor. I should have been more specific. Okay. So actually, this talk is going to be a conversation in which, although actually I just found out when I looked at the schedule, I only have half an hour, and I thought it would be longer. So I wanted a chance to tell you mostly about my new book that just came out in May, Optimal Care in Childbirth, The Case for a Physiologic Approach. I'm very excited about it. I want to tell you, first of all, a little bit about how this book came to be. So, I was a Lamaze teacher and a doula, but I had a background. I had majored in biology in college, not done anything with it, just liked it. And as I was teaching Lamaze classes, I was getting people in my classes that were just repeating the most outrageous things that their doctors had said, which I knew because I was curious and interested in the literature, simply didn't hold up. Like about episiotomy, a nice clean cut is better than a jagged tear. Or not using an electronic fetal monitor is like driving your car down the road on the wrong side at 90 miles an hour. These are important back those years ago. So I thought, well, you know what, it would be really useful to have a book that collected the research and had it all in one place so that people could say, well, you know, that's not actually what the medical research supports. And so I wrote a book called Obstetric Myths versus Research Realities. And that was published in '95. And it turned out, basically I was writing the book that I wanted to have on my bookshelf, but it didn't exist. And it turned out other people did want to have it on their bookshelves too, and that was very exciting. But that book, you know, kind of got old in the tooth. And some years ago, I started working on a book which started out being a new edition, but really evolved into an entirely new book. I'd gotten about a year into it with the simplistic idea that all I needed to do was sort of update the research. And as I got into it, I realized I really wanted a co-author, and I knew just the person, Amy Romano, who is a certified nurse midwife, and she had an interest in the research. We had worked together in both directions. I had worked under her for Lamaze because at one point she was in charge of their website content, and I started working with Lamaze on the Ask Kenzie forum, and she was sort of my boss. And then I did a project for the Coalition for Improving Maternity Services in finding the research that supported the Mother-Friendly Childbirth Initiative. And I asked her to be on my expert work group, and she agreed. So then I sort of became her boss, and I really thought a tremendous amount of her. So I asked her to be co-author of the book. Now at that time we thought, again, it's basically we met at her house and just decided to take just a fresh approach. And we basically raised the old book to the ground. And we covered the same topics. Some of the chapters have the same titles, but we basically started again, which was a really good move. And at that time we thought, well, it'll take us, a year, 18 months. 5 years later, after a very long labor, at many points during which one or the other of us was feeling like, why am I doing this? This book came out, and one of the things that kept us going is, we would read our own chapters or each other's chapters, and we would just say, this book needs to be out there. I think we're doing something special. As I said, Amy's background is that she is a certified nurse midwife. She has experience both with home birth center birth and hospital birth, and her own 2 children were born at home, so she also has the personal experience of giving birth at home. And she's a generation younger. She's literally young enough to be my daughter. She's my son's age. So we really, I think, brought some terrific joint strengths to the book. By being of an older generation, I brought a sense of history to the book. I have been involved in childbirth since the original rise in C-sections in the late 70s and the coming in of the technological approach to birth. So I have that long-term perspective of how things have changed. I also have the outsider's perspective, which I think is helpful in the sense that if you're not a childbirth professional, if you're working inside the system or have worked inside the system, or if you're doing home birth and you're a clinician, that does give you a different perspective than from someone who's just looking at the system from the outside. On the other hand, she matched that by having an insider's perspective of what are things like on the ground for clinicians and what do they need to know. Also being of the younger generation, she has been terrifically helpful in that she is much more computer literate than I. She's very knowledgeable about social networking and about the issues that are important to women in her generation who are mothers, which has been terrifically helpful. And then the other thing is that we have different points of view. Like mine is pretty clearly like, what does the research have to say on this topic? Very analytic. And while she has that, she has more of a public health perspective. How do systems work? And are they working well or poorly? And if we're going to do things differently, how do we approach that from the systems perspective? So it made for a nice marriage. So the way we worked the book is we took the lead on different chapters, and we actually in the back of the book say which chapters we took the lead on. But of course we worked collaboratively in terms of planning chapters and bouncing ideas off each other and peer editing and things like that. So when you're trying to write a book like this, which is an analysis and synthesis of the research, one of the things you have to realize is that research is really quite difficult in the sense that, well, for one thing, there's a misfit between how you want to look at physiologic birth and the research model, which is actually a pathological model of you have a disease or you have a problem, and what is the best way to treat that problem. And I think the best thing I can do is read a quotation from Susan Hodges on this point. And Susan Hodges, of course, is from Georgia. You probably know her. The scientific method requires clear definitions, rigid boundaries, limited variables, precise measurements, and overall objectivity. However, these requirements are in conflict with the complex and variable nature of childbirth, for which subjective and imprecise elements, such as attitudes, beliefs, and feelings, of safety, empowerment, comfort, freedom are important. Rigidity, control, limitations, and precision are the antithesis of normal natural childbirth. So already, if you're starting to look at the research, most of the research is done from the medical model perspective that is trying to impose rigid boundaries and limited, definitions and all of that. So it tends not to work very well looking at physiologic birth. So that was one problem that we need to work with. Another problem is that the medical model has held sway over how, in hospital birth at any rate, how women are managed in labor for so many decades that we have what, I think I came up with this term, we have what I would call iatrogenic norms. In other words, if you're going to do a study, you want to look at what appears to be normal. But if what appears to be normal is really an artifact of how women are managed, then you've got a problem. Because the way research works is you have to show that your way of doing things is better than what's already out there. Because if it isn't, according to what your study says, then there's no incentive to change it. Okay? So let me give you an example. Early cord clamping. Well, that's been going on for generations, right? So that is the normal. So whatever values you get for bilirubin are considered, with early cord clamping, are considered to be the norms. So what happens now when you do a study where you don't clamp the cord? You get high bilirubin numbers. But you're not really getting high bilirubin numbers. Those babies aren't sick, they're not jaundiced, they don't have any symptoms, but they're high, abnormal, because what's really happening is your norm is babies who are essentially anemic because they've been deprived of anywhere up to 40% of their blood volume. But then you point to the study and say, well, we really shouldn't be letting the cord stay open because if we do, we get these high numbers. So there's an example of an iatrogenic norm. Similarly, along the same lines, a lot of studies have what I call frying pan versus fire outcomes. So you're going to look at the effects of epidurals versus standard, which would be narcotic analgesia. And you're going to find that, oh, well, babies aren't as sleepy with epidurals, and you don't have as many respiratory problems at birth. So obviously the epidural is better. But what's missing from the picture is you don't really know what a baby looks like who hasn't had any drugs at all. So, it's great that you showed that there's a better outcome with epidurals, but that's not really, you haven't really gotten at the real problem which is what do drugs do to babies at birth, which is far more important for establishing why maybe we want to not, to be finding other ways of dealing with pain of childbirth. Another problem with the way research is structured is it assumes that if you're scientific enough, if you're precise enough, that it's possible to find some sort of objective truth with a capital T that is neutral. But the fact of the matter is that's not true. As long as human beings are doing the research will be driven by whatever their biases are. The biases will determine what you think is important to research. The biases will determine what questions you ask about the topic that you think is important, how you set up the study, what outcomes you look for, how you interpret the outcomes you find. I mean, it affects everything, and it affects it in a subtle way. So again, that's a problem if people who are doing the research are looking at the medical model as their background. So a perfect example is there was a study done a number of years ago that was a randomized controlled trial of walking in labor. I'm not going to be able to remember the precise title. But it was something like, well, walking doesn't really do any good. It doesn't, you don't get fewer C-sections, you don't get whatever. And what it left out of the picture was, first of all, if you actually looked at the study closely, very few women walked and very few women walked very far because of the way the study was set up. Because if you wanted drugs or if you were, like if you needed Pitocin, or there was this long list of things that basically would put you back in bed. So if you looked at the actual data, there was a very small percentage of women assigned to walking who walked more than an hour at most. Most women, many women didn't really walk at all. And then the second thing that they totally missed was that walking was perfectly harmless, and 99% of women who walked liked it. That didn't seem to count because you didn't get fewer C-sections. So there's a bias at work there. All right, so let me talk a little bit about the book specifically. The first thing I want to talk about is the title. Amy and I really worked long and hard and went back and forth with our emails on the title, and finally did come up with Optimal Care of Childbirth, the Case for a Physiologic Approach. And when we did come up with that title, there was this bingo. And on several levels. One was we struggled a lot around what exactly was the model of birth that we were talking about. And the problem is a lot of the vocabulary that's around the model that we were talking about is very difficult. What is natural childbirth? I mean, that's pretty much totally lost its meaning. Up to and including, there's a study out there about a natural cesarean. I mean, I never thought we'd quite get there. But for a long time, natural has meant vaginal, but we don't even have that anymore. And also, natural wasn't the quite right word. Humane, well, that's pretty judgment-loaded. Normal, it turned out that while normal is a perfectly good term if you're coming from the medical model, it's a very heavily loaded term for women. Because it's one thing to talk about. You can talk about normal breathing or normal digestion, and nobody has a problem with that. But you start talking about normal birth and really talking about how a woman's body functions, that's a big problem for women themselves who say, wait a minute, you're calling me abnormal because I wanted an epidural or I had a C-section? So it's a very loaded word. Didn't want to use that. So physiologic best described what we were talking about. But the other piece is we didn't want to just talk about everything going well. The thing that summed it up so perfectly for us was the optimality concept, which was developed by the American College of Nurse Midwives. It was developed as a research concept, but it worked so beautifully for us as well. Because optimal means that it's the least use of medical intervention that produces the best outcomes given the individual state of the woman. And we think that is a really powerful concept because what it means is you need to pay attention to interventions. Within the medical model, if you come out with a reasonably healthy mother and a reasonably healthy baby, how you got from A to B is almost irrelevant. But the moment you start talking about the least use of intervention that produces the best outcomes, then you're talking about a different approach to not only how you handle women who aren't having problems, but how you handle women who are. It also addresses another thing that on the clinician level is very difficult for some of you who are hospital midwives, which is, oh yeah, you want to be nice to the mom and give her supportive care. But it's really sort of an afterthought, and for the woman who has any problems at all of that goes away because now we've got to solve your problem. And the fact that because you have preeclampsia, you're also scared, you still need supportive care. If you're talking about optimal care, then supportive care becomes the default. And if there is a need for medical intervention, it's an add-on. It doesn't take away from the fact that that woman still needs the minimal use of intervention and still needs supportive care and feeling like she's safe and feeling like she's being taken care of and feeling like she's a full participant in the decisions that are made. And all of those things may actually reduce your blood pressure. So that's how we got with the title. And the book is organized in that we have some introductory chapters that talk about how this book came to be, we have a chapter on the failure of obstetric research, and we have a chapter about sort of the nuts and bolts and methodology of the book. And then the main chapters of the book have an essay that talks about various issues, and then it has mini reviews of the literature, which I'll explain a little further in a moment. And at the end of the essay, we have optimal strategies for labor. So what we were after is, first of all, rigor. We wanted to come as close as we can to doing what's called a systematic review. Like, there are basically two kinds of reviews. There are narrative reviews where somebody has a point to make, and they sort of cherry pick through the research to find the bits that support their point of view. And actually, for all its strengths, Obstetric Myths versus Research Realities was a narrative review. But this book, we did set up ahead of time what criteria, on what basis we would include or exclude a study, as systematic reviews do. And if we had a study that kind of fit our criteria, but we felt the study was unacceptable for other reasons. Well, actually the most common reason was the study was included in a systematic review that we were using, and we didn't want to sort of double dip. But we did have studies that fit our criteria, but we felt had problems of other kinds. So this piece is on our website. Originally it was supposed to be in the book, but as you can see, anything that we could take out of the book was a good thing. Yeah. One thing about this book is when it gets out of date, you can repurpose it as a doorstop. But anyway, that piece is on our website, but we do have studies that we excluded and why we excluded them. So we gave the book rigor, which we felt was important. Another thing we did that was to quantify risks, because one of the things that we felt that is a problem is if a woman or a clinician actually is trying to help a woman make a decision, it isn't enough to say to her, well, if you have a cesarean, there's an increased chance of whatever. The woman really needs to know, well, how big is the difference? So one of the things we did, actually I handled, because this is sort of my métier, I handled for the cesarean, the VBAC, the induction, and the epidural chapters. The essay is largely about quantifying risks. So here's an example. In the case against liberal use of cesarean surgery, it says 9 to 25 more women, here's the first of them, 9 to 25 more women per 100,000 die of causes directly attributable to cesarean surgery compared with women having vaginal birth. 4 more healthy women per 10,000 having elective primary cesarean surgery have peripartum hysterectomies compared with healthy women planning vaginal birth, which means some of them would have had C-sections. And 11 more women per 10,000 with no predisposing factors having primary cesarean surgery have peripartum hysterectomy compared with women having vaginal birth. So now you actually have the numbers, which I don't think anybody else has done. But interestingly enough, I heard Amy speak at the ACNM conference, and she was speaking on the transforming maternity care, and one of the things is, and she was speaking on what do women need to make informed decisions, and one of the pieces that is now present in the research about medical decisions in general is exactly what we put in the book, was they need to know how often, how much, what is my real risk before I can make a decision. The other thing is that we recognize that we had biases too, surprise, surprise. So we couldn't claim to be objective any more than the people who are doing medical model stuff. So what we said is, you know, you can't be objective, but what we can be is transparent. So that's the main reason for the mini reviews, is we lay out the research for you, and you can make up your own minds, or you can go and get the studies yourself, whether we've made a strong enough case for whatever point that mini review is supporting. The other thing, as I said, which I think is important, is every chapter ends with optimal care strategies, some of which are sort of best practice. It's not so much supported by the research as makes common sense, like women having freedom of mobility in labor. We can't actually make a strong case for that based on the research. But what we can make a case for is nobody has shown that it does any harm, and women like it, and it does appear to do some good. So women should be able to do that. And finally, we have a couple of appendices that cover kind of things that fit into multiple chapters that we thought were important enough to to have a short section and strategies for optimal care. And we have two of them. One of them is called Optimal Care for Protecting Mental Health, with the subtitle, If Mama Ain't Happy, Ain't Nobody Happy. And the other is Optimal Care for Some Not So Optimal Babies, in which we covered the plus-size baby, what's the big deal, the malposition baby, rotation, 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 and the baby with meconium staining, meconium happens. And then also, at the very end, I thought this would be something that would be important to add, is we have an index of the mini-reviews tied to the pages. So suppose you wanted to make a case for at your hospital for not having routine IVs. You could look it up in the index where that particular mini-review is, and then you have all the research at your fingertips to make the case on that particular issue. Easy to find. So that's kind of about the book. Now, about the essays themselves, at least for my chapters, one of the things that was the burning issues for me was the drivers of maternity care. Because the huge question for me is, almost everybody involved in the system wants healthy mothers and healthy babies. I mean, really, there aren't that many people who just don't care. And given that you do have this very large body of research that makes the case that the care should be like this, then the question becomes, why is the care like that? Why is there a gap, I may even say a chasm, between what we know produces the best outcomes and the healthiest mothers and babies, and what standard management is? And so a lot of my chapters were about what are the other drivers. And the reason is that one of the hopes that we had for this book is that people could use it to make change. And if you're going to try and make change, you have to know what's holding things in place, so you know what your challenges are. And we didn't, for the most part, I mean, that's a different book, talk about how to make change, but we're going to hold your coats for you and give you the research that will help you do that. So basically, I know that malpractice is the one that gets bandied about. And first of all, that's a problem because what defensive medicine says is that it's an ethical issue to me, which is that it's okay to do things to women so that I don't get sued. But the American College, or Congress as it's now known, of Obstetricians and Gynecologists has an ethics statement which says that where there's a conflict of interest between the doctor and the patient, then it must be resolved in the best interest of the patient. And I would say that not wanting to get sued falls under that category. So there is an ethical issue with defensive medicine. But the other thing about it is, it doesn't work. I found the results of a 2009 survey of ACOG obstetricians in which 91% of them had been sued. So if your point in doing things the way that you do is to prevent lawsuits, it's not working. And so as Michael Klein said, you're going to get sued anyway, so you might as well do the right thing. So that's one thing that I sort of dismantled, was the idea that defensive medicine is a driver, and you have to deal with that, but that one's kind of bogus. But I think the other two major drivers are beliefs. You know, the medical model holds that pregnancy and childbirth are difficult dangerous experiences in which the only thing that holds disaster at bay are the skills of, well, not even just a doctor, but a surgeon who specializes in the pathology of women's reproductive organs. So that's really a major driver behind the medical model, is different ideas of what safety means and what constitutes safe care. And I think it's important for people to understand that. And then the third thing, which I think people really don't, are just beginning to get, is the economics of the situation. Because if you start talking about midwifery model care being safe and effective, and then you talk about, okay, you can make that argument, but if you're going to talk about it, well, it's cost effective, that's actually a negative argument. Because from the hospital's point of view, it's about revenue generation. And if you don't know that, you're going to be kind of barking up the wrong tree. It's true, it's cost effective for society. But that's actually a problem from the hospital's point of view, and I think it's important to know that. The ideal delivery from the hospital's point of view is a scheduled C-section. It's also ideal from the doctor's point of view, less about money, and more about time management. So, this is supposed to be a brief talk, a little bit briefer than I expected, but I would like to at least take a few minutes to find, and let me tell you, this book is for sale through the bookstore, and I will be signing copies. We did have one small problem, which is that they ordered 30 books, which was a full case and a half a case, and they got the half a case. But what I discussed with them, they can't find the full case, it's just not here. So, but what I discussed with them is if they sold out, I imagine most of you are local, so I suggested that if they wanted to take your orders and your phone numbers, if you're local, you could actually drop by the bookstore and pick it up when we locate the books and get them to them. So I just want you to know that. You only have one mic. All right, well then I'll come to the front and yell. Or maybe they can sort of, you know what, we'll just let people talk to me, I'll repeat the question, and then everybody will hear it. I think that'll go faster. So I'm just wondering if you guys have comments, if you have burning issues, if, okay. Okay, so we have a midwifery student who's saying, maybe it's a matter of education. You have people out there who've been educated back in the day, and they're just not familiar with the new research and what it has to say. I'm afraid, this is one of the things where having the historical perspective helps. I'm afraid I've got bad news. And the bad news is that when the cesarean rate started going up, there was this sort of feeling like, well, gosh, when it hits 25%, it's just going to be so incredibly sky high that everybody's going to wake up and say, we just can't be doing this. We need to do something about this. And that's not what happened. For a while, it stabilized, and it went down a little bit to 20%. It was never less than 1 in 5 because people were doing more VBACs. And then when that disappeared, it soared again. We're now at 1 in 3. What happened? Well, the problem is, as the technological model took over, the new docs are being trained. They've never seen a normal birth, or they've actually never been with a woman in labor. They're being trained to think that cesareans are not only harmless, but superior to vaginal birth. And things are actually getting worse. I mean, one of the things that was disturbing to me was there was this very large study. I can't remember the acronym, but there were like 19, it was the Safe Labor Consortium. And so what they did was they looked at huge numbers of women, getting the data from 2002 through 2008 from like a couple of 100,000 women at 20 different institutions, like 17 of which were teaching hospitals. And the cesarean rate and the induction rate were appalling, including, as the studies are coming out, that they're not being treated according to the evidence. Things like 50% of first-time mothers who are induced are having their C-sections for failure to progress before they get to 5 centimeters. So they're having them when they're not really in progressive labor. And the thing that jumped off the page at me is if 17 out of these are teaching institutions, that's what residents are learning. So unfortunately, things are getting worse. What we really need is environments in which, and there's a few hospitals, teaching hospitals where this is happening, where the residents are trained by midwives in normal birth. But I'm sorry to say, also the other problem, this disturbs me a great deal, is with the emphasis, well, back when I got started, there wasn't much evidence out there at all. And what there was evidence versus opinion, because what evidence was out there did support things like you shouldn't be doing episiotomies and things like that. But as the pressure to practice evidence-based medicine grew, you had more and more people who were doing research from the medical model and really had an agenda. I mean, there are studies out there that it's real, that like Hannah's studies, which have been enormously influential about breech and inducing at 41 weeks and all of these things. And if you actually look at the studies, they are so flawed that it's hard to believe that it was innocent. So what's happening is the research is being peppered more and more with, well, the study looks like a duck and sounds like a duck and walks like a duck, but it's really a turkey. And then it gets cited as being solid evidence for doing whatever. I think a prime example of that is the systematic review that came out of the 2006 so-called maternal request cesarean conference, which is really about elective cesareans. And if you're searching in PubMed, you know, it gives you related studies that pop up next to it that you can click over on. And I can't tell you how often that systematic review or pieces of it come up if you're researching any topic. Or you'll read an article that cites it as showing that elective cesarean is actually no big deal. So this frightens me terribly because it used to be you could at least make the argument, well, that's the opinion, but here's what the research says. Well, what happens when you're trying to make the argument, but well, the research, I know that he says the research says this, but those aren't very good studies. I mean, here's what the research really says. No one, you know, oh sure, you know, you can get the research to say anything you want, so you have your story and he has his story, so it's gotten very much more difficult. And I just don't know what happens when the well is poisoned sufficiently, like where do we go from there? The bright thing is, the thing I have hope about, is that you have more and more studies that are being done from a physiologic model of care. So there are some really good studies out there, or even progressive medical model studies who are critiquing, you know, coming up with things that are critiquing the medical model. So there is some hope. Okay, so we're past time, so I can only take one more question. Yeah. Well, can I take her too? Because, yeah, go ahead. Yeah, I know May's sitting in the front row and she's nodding because she's collected A fair number of names on the maternal mortality quilt are cytotec deaths. How many? 13. Breach is not covered, yeah. That was one of the things, of all the things that we were working on, we didn't do breach. So I apologize for that, but we definitely cover cytotec, and we cover induction for oligohydramnios. The problem that you're seeing is you can always find a reason to do what you want to do or not do what you don't want to do, and that's unfortunate because, unfortunately, I mean, in this climate of fear, you can scare a pregnant woman into doing almost anything you want her to do. The Aussies have a wonderful term for it. They call it waving the shroud. Because basically, a pregnant woman wants the best for her baby. So if you tell her that, basically, if you told a pregnant woman you need to cut off her arm, 99% of pregnant women would hold out their arms and say, how high? And that's unfortunate. And one more question. You were told. So we have a nursing student who's a salmon swimming upstream, and she's wondering, she's not meeting with much success at trying to talk to people about the model of care that should be provided, and she's being shut down, and what's she going to do? First thing I would say is find like-minded people, whether they're nursing students or not, but a support group that you can turn to both to debrief and keep your head on straight and all of those things that you need to do. Sort of a topic for this is not my strength, but keep working in, you may well find other students or practicing nurses who think the way you do. You might, as when you're looking for a job, look for an environment where at least there's, more of a congenial to the way you think things ought to go. One thing is, I actually use it as my signature, which I think can help people from burning out. It's from the Talmud, and it's a quote that says, "You are not obliged to complete the task, neither may you depart from it." So what it's saying is, at least what it said to me, which was just one of those epiphany moments, was that just keep hoeing. What it says is, it's okay if you can't fix things. Just keep hoeing your pea patch. If you're in the place doing what you're supposed to be doing, then just keep doing it. And that's all that you're called on to do, is try and do your bit to make the world a better place. So I think that's a lovely close. I will be back for my the main presentation. This was just kind of like the cartoon that comes before, and I think that's in about 20 minutes. So my main talk is preventing the preventable cesarean, and that's really aimed for the public, but I think all of you might find it helpful and interesting as well. So I'll see y'all real soon.
Notice about these babies hitting the level
A few quick announcements. I want to thank all of you subversive families for coming here and rocking out with all this great new information. When you leave here, all of the pregnant families, bathrooms are straight back against the wall. If you take a right, you'll go into the Piedmont room where our silent auction is being held. There's some really good gift baskets, a whole year's supply of prenatal and postpartum vitamins, fancy upscale strollers from McLaren, lots and lots of gift certificates, raffles where you can win lactation support, really, really good stuff. The silent auction closes at 4 and you must be present to win. So you can put your phone number on if you want to get called, and we will announce the winners and you can collect your prizes. There's some really great stuff. We have several Moby wraps and other baby carriers over there. So go into the silent auction. There's also a used baby item yard sale to benefit the Beth Miller Cancer Foundation, local midwife with cancer. You can get really cool items. They have some strollers, lots and lots of clothes there, cute baby stuff, makes great gifts. Please do visit all of our vendors. They are here to educate and inform. So go get your friends, bring them back. We're going to take a very, very short 5-minute break. Then we'll have another presentation by North Fulton Hospital, who is one of our platinum sponsors. They really helped make this event possible for us in getting this space. And then Hensie will come back and we'll talk about preventing the preventable C-section. Thank you so much for coming. We're about to get started again. I hope you all got to swing by the silent auction. Remember, it closes at 4. Great opportunity to get some really, really cute stuff for really good prices. If you are not pregnant or nursing, you can always get those things for a friend. Cool baby shower gifts. Once again, the silent auction is in the Piedmont room, which is straight back and over to your right. For those of you who need to sign the sheet for your continuing education credit units, the sign-up sheet for that is now at the water station in the back corner of the room. I'm pleased to announce Lindsay Harbour, who is from North Fulton Hospital, who's our platinum sponsor. They've worked very hard to make this Bellies to Babies event happen here so that we could bring these lovely, lovely women to come and speak for you and to educate our families. So without much more delay, I'm going to invite Lindsay up to take the microphone and do a quick presentation. And after her presentation, Hensie will be speaking again on preventing the preventable C-section. Thank you so much. And come on up, Lindsay.
We are so excited on behalf of North Fulton Hospital to be a sponsor today of the Bellies to Babies event. We are going to show a brief video to talk a little bit about North Fulton Hospital and our C-section rates. But first wanted to tell you, first of all, I want to tell you how much I am so excited to be here today. I do not have any children, and I have to tell you I'm in awe of every one of you as I'm sitting here waving, and I see you run that way, and somebody's breastfeeding their baby, and I really appreciate you coming out on a Sunday afternoon. To tell you about North Fulton Hospital, North Fulton is located in Roswell, Georgia, and we are one of the very first hospitals in the city to offer water birth options for women. Now there's 2 in the area, but the hospital was the very first one to do so, and we still believe in birthing options for women and for mothers, whether you want to consider water birth or a natural birth option. If you want a midwife, we do that. And we also strongly encourage VBAC deliveries. And because of that, North Fulton Hospital has one of the lowest C-section rates in the state of Georgia. We've been maintained that for years. And that's a little bit about what this video is about. We're happy today to be here co-sponsoring the event with Atlanta Midwifery. And Dr. Frederick is here, and he and a few other doctors came together a while back to talk about how to allow women who want a midwife delivery to make sure they get it. Because so many times you go in there and maybe the doctor, maybe the midwife is not there, or a doctor has to come in. And they wanted to just encourage that a midwife is always there, and unless medically necessary, you receive that midwife delivery. And so you're going to hear a little bit of a video from Dr. Frederick and myself on VBAC deliveries. And again, if you have any questions, Dr. Frederick's here, I'm here. But thank you so much for being here today. Jeremiah has been my wonderful AV person today. Thank you so much, because I would have been in a real bind without him today. Again, Dr. Frederick is here, who is an OBGYN physician and also with Atlanta Midwifery. The hospital, whether you want an OBGYN or a midwife, we offer all options because we understand that it's your delivery and it's your experience, and we want to make sure that we do everything that we can to provide you with that experience while also maintaining the protocols and necessary to make sure that it's a healthy, happy baby for you and for your family. So I am going to reintroduce, I feel like at first I'm going to start up there, and I've got to introduce Nancy Goer, but we are so glad to have her today. She's going to be giving a keynote presentation, and I think she probably needs this microphone that I'm hoarding from her right now. Nancy Goer is an award-winning medical writer and an internationally renowned speaker, and an expert on evidence-based maternity care, and a pioneer in advocating informed choices in childbirth. Goer has written numerous books, consumer education pamphlets, and articles. She is currently a resident expert on Lamaze International's website, where she moderates the Ask Kinsey Forum and appears as a regular guest blogger on science and sensibility. Goer was a doula for more than 20 years and a Lamaze educator for 10 years. Please join me in welcoming Nancy Goer. Okay, so do you know how long this talk is? How long that they have on the schedule? All right. So who have I got out there? Doulas, midwives, child educators, nurses, nursing students, midwifery students. I know we have at least one obstetrician in the room. Any others? That was going to be my last question. Is just pregnant women who were just good, just wanting this in. Okay, lactation consultants, but this really doesn't cover your. This is going in and out, and I'm not sure why. But we'll do the best we can. Right. So this is going to be our roadmap. Why should you care? What's a reasonable cesarean rate? Why can't you assume that your doctor or midwife knows best? And what strategies can prevent a preventable cesarean? And that would be during pregnancy or during labor. Well, let me first ask you guys, why should you care whether you have a cesarean? What have you heard about the benefits and harms of planned cesarean versus Anybody out there? Why should you care whether you have a cesarean? Do you want to have more children in the future? Tell me more. Okay, so there are consequences for future pregnancies. Somebody in the back? Okay, because we don't actually know what the long-term consequences are. We don't have a lot of good research on that. I'll take two more and then I'll go on. Have you died in a C-section? Now, sometimes that's because what led up to the C-section
was, okay, so she's saying it was doctor error. It wasn't because of whatever illness might have led up to the C-section. Yes, and we're going to talk about that in a second. There's an increased mortality rate associated with the surgery, not what might have led to the surgery. Okay, emotional aspect. This is a very knowledgeable audience, I can tell. Let me just take like one more, and there was that lady in the bathroom and move on. So postpartum recovery, and you can see, I like to collect quotes, and you can see that, and you can, I hope you've read the one that's up there. Now, the two main claims about liberal use of cesarean surgery are that it decreases perinatal deaths and serious morbidity, and that it protects against pelvic floor dysfunction. So let's see what the research has to say about that. It does not decrease perinatal deaths. It doesn't decrease incidence of cerebral palsy. It does decrease delivery injuries. However, fewer than 1 per 1,000 more babies born spontaneously will experience major trauma than with a cesarean delivery. And major trauma in this particular study was brachial plexus injury, which is an injury to the nerves complex that serves the shoulder and the arm and the chest wall. Or it was intracranial hemorrhage, or it was a skull fracture, but almost all of the cases, like 90% of the major traumas in the series were brachial plexus injuries. And what's more, we don't even know how many of those babies who had an injury at birth actually made a full recovery subsequently. And it also does not decrease intracranial hemorrhage. So, I don't know, better perinatal outcomes? Not really. How about pelvic floor dysfunction? So, cesarean surgery does not improve sexual functioning or anal incontinence of gas or stool. Now, fewer women do experience stress urinary incontinence, and that's incontinence that's associated with any sort of pressure on the pelvic floor, like during exercise or laughing or coughing or sneezing. But the symptoms were mild enough to have no effect on quality of life, and severe incontinence occurred at similar rates with cesarean delivery versus vaginal delivery. Cesarean delivery does decrease the possibility of pelvic floor prolapse, but again, it's a very small number. And delivery mode is only one of the many features that can affect prolapse of the pelvic floor, or uterine prolapse. And that's without considering that studies do not take into account modifiable harmful factors in vaginal birth management, such as how women are directed to push and in what position, and the use of instrumental vaginal delivery or episiotomy, nor does it consider the benefits of no-risk alternatives to surgery that can relieve or improve pelvic floor symptoms, such as engaging in pelvic floor exercises or losing weight. Now, severe outcomes are rare, but even one that could have been avoided is one too many. So beginning with maternal harms, cesarean increases the risk of maternal death. 9 to 27 more per 100,000 women will die of causes directly attributable to the cesarean surgery. There was a recent California analysis of maternal mortality between 1999 and 2008, in which 50 out of 95 deaths were from causes directly related to the current or prior cesarean surgery. We also know that 21 more women per 100,000 will die with elective repeat cesarean surgery compared with planned vaginal birth after cesarean. And also, in an article, this is an online journal. It was this quote from the director of the California Center for Family Health. The increased risk for every maternal death, there are 10 near misses. For every near miss, there are 10 severe morbidity cases, such as hysterectomy, hemorrhage, or infection. And for every severe morbidity case, there is another 10 morbidity cases related to childbirth. So the source of this, as you can see, is the increased maternal, really just the tip of the iceberg. But now let's look closer at some of the other excess risks of cesarean surgery. $11 more per 10,000 women with no factors predisposing to hysterectomy, compared with similar women having a first vaginal birth. Women are also at increased risk of surgical injury, and of course surgical injury to organs or blood vessels does not occur during a vaginal birth. They're also at increased risk for cardiac arrest, anesthetic complications, and what are called thromboembolic events, which would be deep venous clots, pulmonary embolism, or stroke, and also for the need to go back into the operating room because they're having a problem that needs to be addressed through more surgery. There are also an incidence of rare, life-threatening complications, wound disruption, infection, we just heard from the floor, experiencing infection during a surgical recovery from a cesarean, and this, of course, is despite the fact that it is the norm to give women prophylactic antibiotics, either before the surgery or during. And now, of course, we have MRSA is out there, which is a very scary potential consequence, and there have been some deaths related to MRSA infections following cesareans. And we have more severe and longer-lasting postpartum pain. A survey of U.S. women found that 22% of women said that pain interfered with routine activities, or quite a bit, in the first 2 months after surgery versus half that many women after vaginal birth. So not only do you see more hospital readmissions after discharge, but you also see them sooner after discharge and for longer duration, which suggests, compared with vaginal birth, women seem to need them to be readmitted to the hospital are having more severe problems after vaginal birth, in addition to just more women after C-sections being readmitted. Nearly half, 45%, of women with cesarean delivery in a survey said physical problems interfered with baby care versus 1/4, 27%, of women after vaginal birth. So there again, as somebody did mention, postpartum recovery. 18% of women in that same survey experienced some symptoms of childbirth-related post-traumatic stress disorder, and 9% met all the criteria. Now, not all of those deliveries were necessarily C-sections, but many were likely to be, because cesarean is more likely to have the components that tend to predispose to PTSD, such as fear for your safety, or the safety of someone you love, feeling out of control, feeling like you're powerless, feeling, those are things that are more likely to occur in unplanned cesarean. And studies also show that women with C-sections are more likely to experience poor overall mental health and lower self-esteem. Although I have to say those studies are a little older, and before cesareans became quite so normal, So I'm thinking that that may somewhat be disappearing. Now, we also have long-term. 1 in 5 women in the survey was still experiencing incision pain 6 months or more after the surgery, versus 1 woman in 50 experiencing a painful perineum after vaginal birth. Adhesions are a cause of chronic pain and can cause twisted bowel even years after the surgery. Endometriosis in the abdominal, uterine, or skin wound is caused by iatrogenic seeding of uterine lining cells during the surgery. Women with cesarean scar endometriosis experience generally cyclic pain and in rare cases have developed intractable hemorrhage requiring hysterectomy or have had the endometriosis devolve into cancer. The only curative treatment is wide excision of the affected tissue, sometimes requiring grafting, and even then it sometimes recurs. And this is one of the things that's starting to be looked at. And it's interesting because one of the very first posts that I did for Lamaze's blog, Science and Sensibility, was about cesarean scar endometriosis. And it's several years old at this point. And there's just right now, there's a new post to it from yet another woman saying, oh, I found this is what I'm experiencing. They told me they didn't know, who finally got her diagnosis, because this is something that has not been on people's radar screens, are these long-term effects. And one of the reasons why in this case, I think, is because this doesn't develop until often years later. So there's less suspicion of what might be going on. And so I think a lot of women are not being diagnosed. And then the other thing that kind of worries me is that the studies in the case series are all of women that had surgery for it, which makes me think there's probably a heck of a lot of women out there who have either decided not to undergo surgery and are just living with their pain. All right, well now let's look at excess newborn harms. So turning to the baby, cesarean increases the risk of newborn death. There was a study that looked at neonatal death in 8 million U.S. women with no indicated risk listed on, no risks listed on the certificate. It's possible that something didn't get listed, but that's what they had to work with was the birth certificate. These were babies that were singleton. There was one baby, the baby was full term, the baby was head down, there were no medical risk factors listed. There were no complications of labor or delivery reported on the birth certificate. You all know that there's 2 birth certificates. There's one that you take home that has your baby's name and information on it. But then there's this whole other form that goes to the U.S. government that has all kinds of questions about the labor and, the prenatal course and all that. So they compared women who were planning vaginal birth in this category, 8% of whom had C-sections, with women having elective C-sections. In other words, there wasn't any reason why they were having this C-section. And they found 1 excess death per 1,000 in women with elective C-section. And then they said, okay, well, we still really don't, let's refine this. So they controlled for factors such as birth weight and whether the mother smoked, and they excluded infants that had congenital anomalies because that might have led to C-section and also increased the risk of death. And then they also excluded infants with low APGAR scores because those might have been emergency C-sections, and again, that baby might have been in trouble, and that might have led to the C-section as well as the death. And again, they still found that newborns were 70% more likely to die in the C-section group. We have surgical cuts, generally minor, mostly minor, but nonetheless they're there and they don't happen in vaginal births. And we have respiratory complications that are a problem with planned cesarean. And that is a problem, by the way, that is not entirely averted by scheduling your elective delivery at 39 weeks. There still is an excess, but it's small. Among women intending to breastfeed exclusively, and intent is important, 16 fewer women per 100 were exclusively breastfeeding 1 week after birth, after a cesarean versus a vaginal birth. And you should know that even in developed countries, formula-fed babies are at an excess risk of serious illness and death. Cesarean delivery is associated with the development of childhood autoimmune diseases even after adjustment for correlating factors. Now, there have been a couple of explanations for this. It's like, why would that be? One explanation is differences in intestinal flora. Gut flora, what's living in your intestines, is one of the things that mediates immune tolerance. And gut flora in babies born by cesarean differ from babies born vaginally for a couple of reasons. One is that the babies aren't exposed to the vaginal bacteria as they pass through. And another is that women who are having cesareans are given prophylactic antibiotics to prevent. Antibiotics also can cross the placenta and be found in breast milk, which again would affect gut flora in the newborn. And another theory is that cesarean infants are prone to have excess fluid in their lungs, and that causes a more or less temporary problem called transient tachypnea of the newborn, which is rapid breathing. But there are studies that show, and also respiratory distress syndrome, but there are studies that show that both of these are associated with increased risk of asthma, which is one of the immune disease problems. And recently, a US study found that more children delivered by cesarean were highly overweight at age 3 compared with children born vaginally. And the association with cesarean held after they took into account everything that you can possibly think of that might be associated with cesarean and having a high-weight child. So, for example, how much the mother weighed, and what her glucose tolerance was, and how big the baby was, and a whole bunch more. Differences in gut flora also provides a plausible explanation for increased risk of childhood overweight with cesarean delivery. But there are also other effects of cesarean delivery on inflammation, immune, or endocrine function that might also play a role. Now, I put the question mark there because there's actually a Brazilian study that did not get that result. So this is one where we don't know what we don't know. More research is needed on this one, but we're finding more and more things that seem remote from the cesarean, but actually appear to have some relationship. Well, the other thing about cesareans is it's the gift that keeps on giving. So once you've had one cesarean, you have consequences for the rest of your reproductive life. Placental attachment abnormalities increase the risk of severe morbidity and mortality. We have placental abruption, which is that the placenta detaches partially or completely before birth. And interestingly, with placenta previa, which is the placenta overlays the cervix, we have a greater likelihood of severe complications in women who have placenta previa after a cesarean delivery in their next pregnancy than in women who have never had a cesarean. Placenta accreta is where the placenta grows into the uterine muscle and sometimes through it, invading other organs. And it is the most dangerous of the placental attachment abnormalities. Cumulative deaths in 8 studies that I looked at was 4 women out of 468. And that's 9 women per 1,000. So that would be 900 women per 100,000, which is the usual way that we report maternal deaths. Women with placenta previa are more likely to have placenta accreta as well if they have had a prior C-section. 2/3 of women with prior cesarean who have hysterectomies have them because of placenta accreta, previa, or both. And placental abruption also increases the risk of likelihood of hysterectomy. So here's a quote from a study that kind of projected out into the future. and concluded that if the U.S. cesarean rate continues its upward trajectory, which by the way, it's flattened out, so that's sort of good news, but it's flattened out at 33%. So, but at least it's not continuing its upward trend. By 2020, the increasing number of cesareans and the consequent increase in placenta previa and accreta will result in nearly 4,000 more hysterectomies and 130 maternal deaths annually. So let's look at the excess reproductive harms. They include infertility, and that might be involuntary, can't have a baby again, or voluntary, I'm never going through that again, but it still means that the woman does not have the same completed family size as she was planning to have. We have cesarean scar ectopic pregnancy, and that again is unique to cesarean delivery, and it's a case where the embryo implants in the cesarean scar, which of course will invariably be fatal for that pregnancy baby, and as with any ectopic pregnancy, it's highly dangerous for the woman. 9 out of 10 studies reported an increase in stillbirth with prior cesarean compared with prior vaginal birth in the next delivery, accounting for factors that could increase both risk of stillbirth and cesarean delivery. So for example, well, the mother had preeclampsia in the current pregnancy, or she had placenta previa in first pregnancy, and that's likely to repeat. So they took those into account. And I'll add too that this excess is probably an underestimate, because some of the studies excluded women with complications that are more common with prior cesarean, like placenta previa. 3 out of 4 studies reported an increase in stillbirth plus deaths in the first week with prior C-section. 3 out of 4 studies reported an increase in preterm birth. And 2 out of 4 studies reported a slight excess in small for gestational age. Now, any excess in this would be especially concerning because it suggests that prior cesarean may be compromising uterine and placental blood flow. So that means that's a baby that's undersized regardless of its gestational age at birth. So it's like, something was not going on there. But the evidence for this is quite tenuous. Still, it's something we need to be looking at more closely and more rigorously. So, delivery, cesarean, compared with first delivery vaginal, at the next delivery you will get 1 more blood transfusion per 100 women, 1 more intensive care admission per 100, 4 more hospital readmissions per 1,000, and 1 to 9, depending on which study you look at, that's the range, more per 1,000 women hysterectomies compared with 1 or more prior C-sections, compared with women who only have prior vaginal births. Let's put up that slide up there. Again, with the first delivery cesarean compared with the first delivery vaginal, at the next delivery, 1 more infant per 100 will require ventilation, and 1 more newborn per 100 will have a hospital stay longer than 7 days. And now, let's take a look at the escalating risks of accumulating cesareans. Now, why do we... Well, because, often it's said like, well, if she's only planning on having 2 children, we don't really need to look so much at that. However, 1/3 of U.S. women will go on to have more pregnancies than 2, intended or unintended. So how many in this women in this room had more children than they thought they were going to have when they thought about, oh, we're going to have children and we're going to have however many? Yeah. So even if a woman does not plan to have more children after her second child, still need to look at the problems with escalating cesareans. Because with the VBAC rate under 10%, in 2008, which is the last data that we have, it was 8%. It's unlikely that any woman with a first cesarean is going to have a VBAC. I mean, she's going to have to look hard and work hard for it. So we need to look at the risks that escalate with more cesareans. So each succeeding cesarean increases the risk of placenta previa, placenta accreta, and the two in combination. Now, one explanation, let me see how I'm doing on time. I think I will give you the explanation because I find it interesting. The author of a case series on cesarean scar ectopic pregnancy theorized that the reason that you see this previa-accreta combination in women with prior cesareans is that this is what results when a cesarean scar implantation develops into a pregnancy inside the uterus. So if the embryo is trying to grow in the scar, you get an ectopic pregnancy. But if the embryo is growing outside of the scar, but the placenta is growing inside the scar, you get placenta accreta and previa in combination. Dense adhesions. Dense adhesions make any future abdominal surgeries, not just future cesareans, more difficult. Undoubtedly more dangerous. So, given what we know about the increase in placental problems and other things, it should not be surprising that each succeeding cesarean increases the risk of operative injury, severe hemorrhage, hysterectomy, need for postoperative maternal ventilation, paralyzed bowel, maternal admission to to intensive care, and preterm birth. And of course, preterm birth has all sorts of problems connected with it. So, the next issue becomes, well, we don't want to get rid of cesareans altogether. Some women need them. They're life-saving. And some women, it doesn't matter how much time you give them in labor, that baby is not going to come out vaginally. So the question becomes, what's a reasonable rate? And I think this is probably a knowledgeable room, so somebody here will know the answer. Anybody know what the national cesarean rate is? 33%, 1 woman in 3. Well, let's look at how reasonable that is. Oh, this is the wrong. I don't know why it has yellow lines on it. All right. In 2009, 33 women, in 2010, on this one, 33 women in every 100 gave birth by a major abdominal surgery. Now, the World Health Organization, and there are later studies that back this up, say that the cesarean rate ought to be between 10 and 15%. So, if you look at this, so the crosses, the boxes on the crosses are the cesarean rate. It adds up to 33 out of that box, which has 100 in it. The blue is vaginal births. The crosses are preventable cesareans. The overlap is the difference between 10 and 15%. So as you can see, of every 100 women having babies, 18 to 23, those crosses, are having cesareans that could have been prevented. Now, we don't know which women they were specifically. This is a population basis. But we know there's a bunch of women out there who are having cesareans that they didn't need to have. How do we know that the 10 to 15% rate is actually reasonable? This World Health Organization arrived at the 10 to 15% rate by consensus at an international conference held in 1985 because with some of the lowest perinatal mortality rates in the world have cesarean section rates less than 10%. So they didn't pluck the number out of, and it was the best they had at the time. Since that shows there is an increase in neonatal and maternal mortality when the cesarean rate gets above 10 to 15%. So it's interesting. It's kind of what this study did was do cesarean rates and maternal and perinatal mortality rates and morbidity rates by country and plotted a graph. And it's kind of U-shaped in the sense that you can have too few cesareans. In other words, in an African country where the cesarean rate is 3%, maternal deaths and perinatal deaths can be very high because they don't have adequate resources. And then there's a sweet spot in that 10 to 15% range. And then the rates of maternal mortality and perinatal mortality and morbidity start to rise. Why? Because cesareans, as we've just found out, have risks as well as benefits. And as you start applying it to a wider and wider pool of women in whom that could have been avoided, then pretty soon the risks outweigh the benefits, and you start seeing more women and babies dying as a result of that mother either having a history of cesarean or having a cesarean that could have been avoided. We also have many studies that report excellent outcomes, sort of looking at the other part of the puzzle, with cesarean rates of 12% or less. So there's another piece of data that in lowering the cesarean rate, we would not be sacrificing mothers. Anybody want to guess what the cesarean rate is in first-time mothers? Not the cesarean rate overall, but in women having their first baby. Yell, I can't hear up here. Oh, it's not that bad. Think that 1 in 3 first-time. So it's a reasonable rate, and this is a little hard. I don't know what the overall rate of hospital birth, but those would be women at no risk. The cesarean rate should not be more than 10%. Even those mothers who are healthy mothers planning home births, some of them are going to end up with C-sections, and from some big studies, percent is the number. In low-risk women, target rate, according to the U.S. Healthy People Goal, and most women are low risk. Low risk is defined as she's at term, she has one baby down. She might have medical problems. But anyway, that's what the U.S. government says. But I put a question mark. First of all, most mothers are low risk. Yeah, I thought I had the number for that. I don't know, maybe it's on the screen. Yes, 73% of first-time moms are low risk. But I put a question mark next to that because I don't know that we actually have any data that support 15% as that magic number. But in any case, we aren't matching that low 15% number, even if that is the sweet spot for the overall population of low-risk first-time moms. Excuse me, I'm running nose. I think I've got allergies. And by the way, that number comes from 2004. So my guess is if they did the analysis on data today, it would be more than 24%. So, I'm not going to ask you for the number, but how many of you in this room, if you're planning a hospital birth, know the cesarean rate at the hospital that you're having your baby? Okay. How many of you are planning a hospital? That was 3. How many of you are planning a hospital birth in this room and don't know the number at your hospital? Okay, a few more hands go up. Well, let's take a look at what we know. Now, these numbers were provided to me by a Bellies to Baby person because I asked for them. And in 2007, North Fulton Regional had the lowest cesarean rate. And as you can see, it starts to go up if you find your hospital there. And it starts to go up until we get to North Side at 40%. Now here's the kicker. 2007, This is 2012. Well, what are the current cesarean rates? And the answer is we don't know. We don't know. This came off of, I went to cesareanrates.com, and which will give you whatever data is out there on cesarean rates. It's a great website. And what she had up there was the Georgia Hospital Association confirmed via Twitter on January 27th that the DRGs for vaginal birth and cesarean delivery are null. So you can't find out about what your hospital cesarean rate is because the public health department and the hospitals won't tell you. Gee, I wonder why. Jill, who runs cesareanrate.com, also has addresses on that. Like, if you would like your hospital to make those rates available, she has addresses to write to. So if you want to go to cesareanrate.com and put in Georgia's cesarean rate and pop this up, on that same page will be who to write to say, you should be telling us this. This is a matter of transparency. But as much as we would like to think so, a woman's chances of having a cesarean depend very little on her state rate. A woman's chances of having a cesarean depend very little on the state of her health, or her baby's health, or her ability to birth that baby vaginally. So we need to look at some of the other factors that are in play. And there's some really interesting research on this. There's been a lot of talk in recent years about maternal request cesareans driving the cesarean rate. But the real problem is physician request cesarean. 9% of women in that same national survey I've been talking about reported pressure to have a cesarean. And that pressure works. 25% of those who actually ended up with a C-section said they felt pressured into having one versus 2% of women who ended up having vaginal births. We also have a study of physicians at cesareans at physician request. 13% of cesareans at labor at a particular hospital were not Georgia, were, I think it was Alabama actually, at physician request. The physician openly admitted that the reason for the cesarean had nothing to do with her health. It was like, obstetrician thought she was too tired, I mean, just whatever, but she had no say in that. Another 3% because of the power imbalance in that situation, request category, and say 16% hospital were physician request cesareans. That's 1 in 6. And that's intrapartum, so we don't know what was going on before they ever got to the birth. We also have failure of informed consent. Again, the same 2005 survey. Almost all women wanted to know all or most complications of interventions. But when in the survey they were asked questions about risks of cesarean, most didn't know, weren't sure, or were wrong when they were asked to agree or disagree with 4 statements on cesarean's adverse effects. And half to 3/4 also didn't know, weren't sure, or were wrong when asked to disagree or agree with 3 statements about labor induction. So clearly women aren't getting the information they need to make an informed choice. We also have the failure of informed refusal. Informed consent is meaningless unless there's also an option to refuse. You can't consent, you can't say yes if it's not meaningful to say yes if you can't say no. And more than half the women who wanted VBAC were refused. This, by the way, was 2000, and women having babies in 2005. I'm sure the number would be higher today. And most women who had an episiotomy were not given a choice about that. I would add, too, that while vaginal birth is a perfectly reasonable choice for most women who have breech babies, it's not a viable option for almost all women. And vaginal twin birth is rapidly disappearing, despite it, too, being a reasonable and sometimes even a preferable option for many women. We have cesareans for no reason. 2001 stats. Women at no indicated risk for cesareans, you had 9% of first-time mothers and 4% of women with only prior vaginal births having a C-section with nothing on the birth certificate to say why. Those numbers might be higher today. Cesareans, about but a Canadian teaching hospital found that 65 obstetricians agreed that, quote, childbirth is only normal in retrospect, versus 2% of midwives. Medicine. The reason for the American Congress of Obstetricians and Gynecologists about face on VBAC 89, this guideline. Anxious person. The obstetricians varied from 19% to 30% relation with their score on a test that measured anxiety as a person. In other words, it wasn't situational anxiety, like I'm worried about what's happening in this labor. These doctors were just, they were being scored on, but they tend to be anxious in general. We also have what I call the casual cesarean. We have a survey of Maine obstetricians in whom they said that 5% of them would perform a cesarean for convenience, for the woman having the certainty of who delivered her, and 7% for labor pain. How many of you have had cesareans in this room? Was the cesarean pain-free? I don't think so. This one is just bizarre. I mean, you know, whatever your opinion is of whether every woman should have an epidural or if they should avoid it or whatever, the fact remains there are ways of alleviating pain in labor without performing major surgery. So this one just boggles the mind. And you can even find women who say, you know, they get quoted in the media, well, I had a cesarean because, you know, I didn't want to go through that pain. Recovering from major surgery is pain-free? This is boggles the mind. A 2004 survey of Portland, Oregon obstetricians who were presented with various scenarios and were asked, would you perform a cesarean under these circumstances? 29% agreed that they would perform it for a librarian in early labor who's fearful of urinary incontinence. And remember, we found out that it doesn't do much for at least serious. 13% would perform it for a physician who is not in labor, but who's tired of being pregnant. And 3% would perform it for a secretary in early labor because she's having painful contractions. I mean, that's a low number, but still. And then we have these that came out of the NIH elective cesarean conference. There was part of that, there was a section on the ethics of performing elective cesareans. And the ones that I'm about to give you were cited as perfectly reasonable ethically for performing a cesarean on a healthy woman. Her ability to take time off from work, her need to have a distant relative in the home around the time of birth, the control of the process offered by cesarean delivery, hospital resources such as operating room and staff availability, economic considerations, and my personal favorite, the unpredictability of the timing and length of labor for a provider's lifestyle and fatigue level. Is there any other surgery that you can think of that a woman would be, that any person, any patient would have a major surgery for any of these reasons? Yeah, me too. All right, so the reason this talk isn't about unnecessary cesareans is because often by the time the decision is made, the cesarean is no longer unnecessary. So that's why, and I have Mary Sagady Leslie to thank for this. She's a nurse midwife who was the one that pointed out the distinction between preventable and unnecessary. So, what do you think is the #1 strategy for preventing a preventable cesarean? But what would that education lead to in terms of the choice that a woman might make? Thank you. So as we've seen, an obstetrician cesarean rate should be 15%. I would say that you could bump it up a little if that obstetrician specializes in high-risk patients or takes backup patients. In general, it's just dealing with a higher risk population. You can bump it up a few percentage points. Now, the midwives take care of low-risk women, so their cesarean rate should be less. I don't know what that number should be, but somewhat less. But what I will say is, you can't assume that a woman is going to be more sensitive or provide more care supportive of physiologic birth than a man. Sex is not the issue here. The second thing is consider choosing a midwife over an obstetrician, but again, you can't assume that a midwife is going to be less interventive or have a lower cesarean rate. But in general, the dice will be loaded in your favor. And all things being equal, midwives are more likely to have lower cesarean rates. But you can't just say, well, I'll go to a midwife and that will solve my problem. Or I won't go to an obstetrician and that will solve my problem. But the second thing is you should choose a hospital with an appropriate cesarean rate and policies supportive of normal birth. Because even the environment of the hospital, like what the nursing staff thinks about C-sections, what options are available to women, what the restrictions are, all of those will feed into sort of the culture of that hospital. Healthy women consider planning an out-of-hospital birth. What the data are is that a planned hospital birth in a screened woman who is appropriately screened, she doesn't have high risks, attended by a qualified home birth provider, someone that knows how to do home births. It's a separate skill set. Even for midwives working in the hospital, if you talk to a midwife who does both, she says it's a different ballgame outside of the hospital. Outcomes are equally good, and there's much lower intervention rates. Take away any of those pieces, and home birth is not safer. Oops. Okay. There. In the interest of time, I'll stop asking audience questions. I would suggest hiring a doula if you're not already thinking of that. But I will ask, is anybody in here not, you're just a pregnant mom and you came to hear this talk today, so you're not particularly knowledgeable about the ins and outs? Nobody? Just one in the back? Two. So I would like to ask how much time you think the labor and delivery nurse will spend with you at your bedside in labor. The entire time. Okay. Any other ideas about that? Or you just have no idea? Well, somebody knows more. So there's more than one study that shows that They spend a certain amount of time just sort of doing administrative stuff, checking things or giving information. But as far as the chief thing that a doula does, which is supportive care, 15 minutes in an 8-hour shift, offering comfort measures, emotional support, or advocating for the woman. 15 minutes in an 8-hour shift, not even 5 minutes an hour. So that's a very powerful reason to have a doula. Also, it would be a good idea if there are factors in your past that could interfere with labor. These would be things such as sexual abuse in childhood, experience with assault, prior cesarean or traumatic labor, things that could sort of hang you up emotionally. And then try strategies to turn a breech baby, because they are quite effective. They will. And it is very difficult to find vaginal breech birth. Consider planning vaginal breech birth. Consider planning vaginal birth with a preterm infant or twins. And absolutely, unless there are strong contraindications not to, plan a vaginal birth after cesarean. But it's hard to find these first three. Refuse a planned cesarean based on estimates of the baby's size. The research does not that. And actually, if you have a care provider who thinks that's a good idea, I would strongly changing care providers, because once you're in labor, you are dependent on the judgment of the expert you have hired to attend you. And if your obstetrician does not think you can birth this baby, it's likely to become a self-fulfilling prophecy. So go back to number one, find a practitioner who has policies and beliefs that support optimal birth, which is the least amount of intervention that will produce the best outcome given the mother's individual case. As these slides will show, and the labor strategy slides show, cesareans don't occur in a vacuum. So refuse elective induction of labor. Do not agree to a convenience induction. Refuse induction for suspected big baby. This is a big one that women are handling. Again, the research does not support it, and it's quite consistent. Refuse induction for pregnancy duration less than 42 completed weeks. And refuse induction if the cervix is unfavorable for labor. If the cervix is favorable for labor, it's effaced, it's dilating, you have a pretty good chance that the induction will work. You don't see much difference. Well, they still have some problems connected with them, but you don't see a much increased cesarean rate. The real kicker is when you induce a woman whose cervix isn't ready to labor. Because the dirty secret about all of the ways that they try to ripen the cervix, whether it's Foley catheters or whether it's prostaglandin E2 or, God forbid, Cytotec, or even just starting off with oxytocin, is you can do a great job of ripening the cervix, but you don't change the C-section rate. Probably because there's more to it than just ripening the cervix. It's a complex process. And if the woman's body isn't ready to labor, there's a high chance she'll end up with a cesarean with an induction. It's that emergence a situation that you've really got to get the baby out, then I would really consider, if you can't wait for the cervix to ripen, whether you want to go for an induction or whether you just want to go straight to C-section or what you want to do. But understand that for casual, kind of lower level reasons, don't do it. Oh, I want to go back to refusing an induction for pregnancy duration less than 42 completed weeks. Here's the thing. We don't have much research on term and when do they go into labor. In other words, actually, because there are so many inductions now, the median time for women to go term, which used to be around let me take that back. In a study that was done of healthy women who reached term, first-time moms, 50% of them went into labor between 37 weeks and 41 weeks, and the other 50% went into labor. That's what median means, is the midpoint. After 41 weeks. It was 41 weeks, and I think it's 41 weeks and 3 days. But anyway, 41 weeks, if you're a first-time mom, is the midpoint in the likelihood of you going into labor. And then there's a pretty steep drop-off. So by 42 weeks, there's just like maybe 10% of women likely not gone into labor spontaneously. So if we're talking about inducing women at 40 weeks, or at this point, 39 weeks is becoming the magic number, we're going to end up with a whole lot of C-sections in women whose bodies weren't ready to labor yet. I mean, you can't, I mean, it's just crazy to talk about inducing women, first-time moms, in the time span that they would be going into labor normally. I mean, there's nothing abnormal about 41 weeks. At 42 weeks, you know, you might talk about that. So here are strategies during labor. You want to make informed choices, and here's a nice little acronym, BRAIN. I give credit if I knew where I got it from, but if it isn't an emergency, and very few things are emergencies in labor, and if it is, you'll know it's an emergency, you want to consider the benefits, the risks, the alternatives, including doing nothing, and the benefits and risks of those. You want to process that, and then think about what your instinct and your intuition, that shouldn't you go on, but it isn't something that you shouldn't consider. And remember that you have the option of saying no or not now. Insist on intermittent listening rather than continuous electronic fetal monitoring. Avoid or delay having an epidural. Keep active during first stage labor. Push in an upright position. Refuse a cesarean that is based solely on exceeding an arbitrary time limit. You have 2 hours to push this baby out. If you don't dilate at 1 centimeter an hour, Ms. VBAC, we're going to take you back to OR. Not every cesarean surgery can or should be prevented, but choosing carefully can save you and any future babies a world of trouble. Thank you. I don't know if we have time for questions. Okay. In case you didn't hear that, they said we have time for 5 questions. Okay, 1. I think that depends on the circumstances. If you're under the right circumstances, you're going to have a conversation about that. Unfortunately, there's a fair amount of leaning on women. There isn't much of a concept that women have the right to make those choices. So I think the best thing that you can do under those circumstances is to present yourself as a reasonable person. So if you just say, no, I'm not going to do that, then you're likely to put it's like, okay, we've got another one of these women who just doesn't care about her baby. So the way I would present that is, here are my reasons for thinking that, and let's talk about what might change my opinion. And what circumstances, let's talk about what's a reasonable thing that I really should reconsider, so that you present yourself as a reasonable thinking. Well, that's a reason to have a doula. Some other things you can do so that you don't get railroaded is, first of all, your doula cannot protect you. Because the reaction to a doula who speaks up for the mother is, who the hell are you? Okay? Been there, done that, got the t-shirt. So you or your partner have to be willing to speak up. You can insist that you're not going to, you only can listen during contractions. You just stay as reasonable as you can, or your partner can do it for you, which is, listen, she's in the middle of a contraction, let's wait till it's over and we'll discuss it. Another thing you can do if it's not an emergency, and this I did do as a doula, is I talk to my couples ahead of time about if it's not an emergency, ask for time to consider it on your own so that you're not trying to discuss things or make a choice with people, with staff members standing in the room who want you to make a particular choice. I mean, obviously, if it is an emergency, you don't want to do that, but you'll know, and those are rare. So those are some things I can think of sort of in the moment. I know it's hard to stay cool. It might help to, it's about them and not me. If you end up agreeing to something you regret, find some way to make peace about that. We all make the best decisions we can in the moment, and blaming yourself afterwards it can be very corrosive. Decide what you want to do about it next, or if you want to complain about it now, or whatever it is. But I think it's one of the tragedies of all of this is, women then end up blaming themselves or feeling guilty or whatever. Anyway, next, I think that was back there, and then the lady here. Okay, so where I would direct them? Okay, well, I think there's some great websites. I'll put my little plug in for mamas.org, which has a whole section on what makes for a safe, healthy birth. Childbirthconnection.org has whole sections on making choices and cesarean and vaginal birth and pain relief in labor. I probably could think of some more. There are great books. There is Ina May's Guide to Childbirth. There's my Thinking Woman's Guide to a Better Birth, which is long in the tooth, but it's still accurate. There's Giving Birth with Confidence. Again, that's Lamaze. But I think you can lead a horse to water, which is suggest things they may want to look at, and then they're making the best choices they can. There was a lady in front. Oh no, she was back there. Okay. I will say, sometimes they can't. That's one of the problems. Mm-hmm. Okay, I think we can take like the highest rate was in the mid-1990s, it was like 1995, and it was 28%, which tells you that if you just allow a woman to labor, 75% of women will birth vaginally. So at its height, when only 28% of women were birthing vaginally after a prior C-section, that tells you that even then, it was not exactly golden. Most women were still having elective repeat C-sections. Okay, we can take one more. If someone have like, you just have to, you've got your hand up, so you win. Ah, okay. Okay, that's one thing that there is, that I do refer people to, and that's, I don't know if there's a lot of research on the Webster technique, which is about breech babies, and does it work for posteriors too? Although posterior is not such, it's interesting, because posterior, you really can't do anything about it in pregnancy, because that baby can rotate back in labor. So the whole idea of prenatal positioning of a posterior is not real helpful, and we can talk about, I mean, there's a study where they did ultrasound scans of women in labor and showed that women could come in with an anterior baby that went posterior, and it went both ways. But for breech, I would say we actually have some evidence that moxibustion, which is applying heat to a particular point on the outside of the little toe, actually works. There's some Chinese studies. And as far as the Webster technique goes, I would say try it, because it doesn't involve a direct manipulation of the baby. So what's the harm? I think the way we need to think about some of these things is for alternative, sort of not mainstream medical model approaches, if you can't see any harm to it, then try it. Even if you're not sure it'll work. Because if it isn't incredibly expensive and there's no harm connected to it, why not try it? And to me, that manipulation by a skilled practitioner, a chiropractor, is certainly worth it. What's your experience with it? Do you do that? Okay, so you do it early, and that's another thing too. If you do have a breech, it's like, don't wait. It's true that most of those babies will turn by turn, but what if you're not the one? So you might as well do something early when there's lots of fluid and the baby's smaller and, yeah, easier to turn. You want to come up to me afterwards, I'll be here, but I think we need to stop. Thank you.
Okay. I'd like to thank everybody for coming to hear this. This was an excellent talk. Thank you so much, Hensie, for being here. We're going to take a short break if everyone wants to exit the ballroom and come see some of our vendors. There's a lunch counter and things. We will be reconvening in this room in a very organized line formation where Hensie, Ina May, and Mayim will all be here to do a book signing. If you don't have your books with you, books are available for purchase right outside the door. There's a gentleman named Chris. He's selling books. He's got books for everything. Our silent auction is going to go until 4 o'clock. That'll be after Mayim Bialik finishes speaking. And you can go get your bids in right now. The current time is 2. The book signing will begin at 2:15. We will begin lining people up at 2:15 for the book signing. Hey friends, welcome to the book signing portion. Ina May and Mayim are here right now. If you have a book that you would like signed by Hensie Goer, she'll be joining us for the rest of the book signing momentarily. And if you can form a line behind Tess and Dominic with the blue ergo and the great hair, and they will help you as soon as Hensie gets in.
Test.
our guests that need stroller parking, feel free to park your strollers along the back wall and then move on to seats if that's most comfortable for you. We'd like to keep the aisles clear of extra strollers, so if you'd like to park your strollers back behind, or if you'd like to move a chair and then replace your stroller where the chair used to be so that there are no strollers in the aisleways, please. Thank you.
Mic check.
Now there might be another two. There might be, but she don't know. And before we stood in that long line thinking we were going to get involved. I don't know. I'm going to go see them on the line over there now. We're standing in line twice. When I looked, it didn't look like it was, and that's a bunch more people got in it because it was all the edges, so I was going to go pee. Oh, really?
Once again, if you're more comfortable parking your stroller along the back wall and taking your children to come and sit in one of the seats, we'd like to keep all the strollers out of the aisle so that everyone is safe and we can get to the diaper changing station rapidly. Once again, please, no strollers in the aisle, and you're more than welcome to park your strollers along the back wall. I'd like to let everyone know we have now closed the lines for book signing. Everyone who's in line now, this is the end of the lines for book signing. We need to move on with the rest of our program. If you'd like to spend more time with our guest speakers, you can get an upgrade to join us in the red tent. Your donation goes to benefit Midwifery International. You can go up to the registration desk if you'd like to join us in the red tent. Here in just a few minutes, Aviva and the Flying Penguins will be serenading us. And then we'll be hearing a speech from our keynote speaker, Ms. Maya Bialik. Once again, stroller parking along the back wall, nice and comfortable, and keeping the strollers out of the aisles. A lot of us are pregnant or nursing or have babies in diapers, and we'd like to be able to get into and out of the building safely without strollers in our way. So please, stroller parking along the back wall of the room. We have a special song to introduce Dr. Maya Bialik. Please sing and clap along.
you very much. So for those of you who, can most people hear me? Can I get like a thumbs up in the back? Okay, great. So no, that song was not written about me, but my name means water in Hebrew, and that's actually an Israeli song and folk dance based on scripture that is basically our version of an ancient rain dance about drawing forth water. So the song was not for me, but as a child, my mother would make me dance to that at Hebrew school. That's not a good memory. Okay. Thank you all for being here. I don't have a watch, but I think that I've timed this right. I'm gonna talk for about 30 minutes. It might be a little bit less, and then we're gonna open up to Q&A until Danielle goes like this, and then we'll stop Q&A. The mic is a little soft, so is everybody still okay in the back? Okay, 2 thumbs up, great. No, I think we're good. I think it's good. I'm okay so far. I'd like to thank our sponsors and the people really who got us here, the North Fulton Hospital, obviously the Holiday Inn for this great venue. I'd like to thank all the vendors who are here. I had a great time, and I hope everybody else did, walking around. And I'd like to also thank, obviously, Bellies To Babies, specifically Karina and Danielle, who physically, literally got me here from the airport. My friend who is housing me and whose husband is hopefully happily taking care of my boys right now, my friend Adi, and also the other distinguished speakers. It's really a true honor to be here with these other amazing women. And anyway, I'm not bothered by normal, chattery, crying baby sounds, so please do not be self-conscious if your child is making normal baby sounds. Please feel free to stay. If other people give you dirty looks, you'll have to figure it out with each other. So what I wanted to talk about was, obviously this year has seen a tremendous increase of a very unusual kind in terms of the discussion of attachment parenting in the media, really on all fronts. It really feels like people who never knew anything about attachment parenting now have something to say about it, and indeed, not all of it has been good. A lot of the discussion of attachment parenting and kind of satellite aspects of attachment parenting have been very gossipy. And it's not necessarily gossipy in the people talking behind our backs way, because once you put it on national television and on the cover of magazines, I don't feel like people are talking about us behind our back. But I feel like the gossipy aspect has been kind of a very a snarky, there's a lot of negativity, there's a tremendous amount of, I'm okay with academic skepticism, but I feel like there's a lot of kind of what I refer to as breaking down and not building up kind of criticism, and I'll talk about that a little more. So as some of you know, or as they're selling here, I was really encouraged to write a book about our family's experiences with many aspects of attachment parenting and some aspects of natural and holistic parenting that fall outside of attachment parenting per se. But I wrote this book and it came out in March, and the paperback actually is coming out in September, which is exciting. It's funny because the Simon & Schuster, who put out the book, had wanted to do a really big push for the paperback in September. And then I got nominated for an Emmy on Thursday. Thank you. But it's good that my publicist had sort of thought this might happen, because they said to Simon & Schuster, we're not going to be able to do a lot of publicity, I think, in September. But hopefully I'll still be able to make a push. Originally my book was supposed to come out in paperback, and then they decided to put it out in hardcover, but I'm glad that it will now be out in paperback. But anyway, I did a book tour for this book, which is kind of what you do. And I was in New York for a week, and then I was in LA, which is where I live, for kind of another week. And, the book tour went really well. And how do you judge how well a book tour goes? What are you booked on? Who wants to talk about it? And I was on The View, which is, again, it's a very broadly watched show. And Nightline did a special on my family. I allowed them into my home. That might be the last time I ever let any crew into my home. Good Morning America did a piece. So these are things that Simon & Schuster likes. They like to know that a book gets seen on those places. Obviously, we did articles in major newspapers and magazines, and tremendous interest and support from both the mommy and the daddy blogging universe. So I wanted to mention, before I get to sort of the bulk of my talk, what were the 5 main things that I was asked, really for all of these kinds of interviews? The first was, what the heck is attachment parenting? And as any of you know, there's not one answer to what is attachment parenting, and I found myself kind of constantly modifying everything I said, meaning you don't have to do all these things, no one's going to take away your license of parenting, there's not an attachment parenting police. But that was the first main thing I got asked, what is attachment parenting? Number 2 was, you have to do all the things. And many of us know it as kind of the Sears list, all the B's. That was kind of the second thing. The third was, how can you be an attachment parent and still work? This is just a lifestyle for people who are at home, isn't it? That was kind of the third main thing that I had to speak to. Number 4, I didn't know how to describe this, but it's called, the way that I summed it up, aren't your kids going to be messed up? And I'm asked that a lot, and again, I don't have an easy, simple answer to it, and if any of you do, then maybe you'd like to finish this talk, because there isn't a way that we know. However, attachment parenting, as many of us would say, is not inherently messing up our children. And the last question is something that is not even part of attachment parenting per se, meaning the guidelines of Attachment Parenting International, but I figured I would mention it here today, because there's people here who are talking about it. What's up with no diapers? That was kind of the 5th most popular question. In our family, we practiced elimination communication successfully, whatever that means. We practiced it with both of our boys, and I did include it in the book, although, as I mentioned, it's not part of attachment parenting per se. Honestly, with all of these kinds of questions, I really felt like I was taking all of you with me. I felt like I was taking all of the women and the men who believe even in one of these aspects of attachment parenting with me. But it really became clear to me, specifically and especially from the experience with Nightline, which was very, very difficult, I really felt like most media was looking for gossip. That was really the overarching feeling that I left with. They were looking for something sneaky, like I kind of felt like maybe they were checking behind my cupboards, like does she have a full staff of nannies that are really doing the parenting? Because no one could parent like this, right? No one could really be with their kids this much. Or I was saying like maybe they thought like my secret is I give my kids medication. I just give them cough syrup all day so that they they're happy and sleepy. Or I also felt, especially with the Nightline experience, that maybe they were looking for, a beaten down husband who I bossed around and, kept slapping in the face every time he said, I don't want to pee the baby. Actually, the joke I had was, maybe my husband's a miserable man, they were trying to find out, that I pummeled into submission so he pretends that he likes me, having him read birth stories from spiritual midwifery every night. He didn't want to hear any of those stories, by the way, but we got through anyway. It wasn't until the Time magazine cover came out that I felt that actually legitimate issues surrounding attachment parenting finally got discussed in this last year. Unfortunately, it took a sensationalized misrepresentation of both breastfeeding, extended breastfeeding, and the larger aspects of attachment parenting to actually start some real dialogue, and that was really my personal experience. So I sort of ended up going on a second inadvertent book tour after the Time magazine cover came out. I was asked to speak on places like NPR affiliates like KPCC. I was on several CNN shows, and honestly, I was the most astonished when I was asked to speak about the cover of Time magazine. That's when I was the most astonished that outlets like CNN, and again, I'm not advocating for CNN, even though obviously in Atlanta I might as well. But it was those kinds of news outlets, it was the NPR affiliates that actually wanted to hear my answers. Meaning they weren't asking a question to get a soundbite to put on their website to then tease the next morning, crazy Hollywood mom, doesn't use diapers, right? So it was very interesting. I kind of had these two experiences with the media. So looking back on this past year, I feel like attachment parenting has really had its day in court, that being the court of public opinion. It really has been a year of not just attachment parenting, but the controversy of attachment parenting. So what I wanted to do for the bulk of this talk, and then I'll open it up to questions, I wanted to discuss, I wanted to whittle down what were specifically the gossipy, controversial aspects of some of the main aspects of attachment parenting, and what is the goodness? What was the goodness that came out of it? Because I really feel like if we can't at least point to, for each of these things, what good came out of it, either for us or for how we're represented in the general community, I really feel like a lot of, well, my book and all of the exhaustion for that might have been in vain, but I don't think it was. So I'm going to talk about 6 aspects, again, each briefly. The first, obviously, is birth. The second, the discussion in the media of breastfeeding and extended breastfeeding. The third, I used all B's just as a nod to Dr. Sears. The third B was bed sharing, and obviously also co-sleeping. The fourth is bowels, specifically elimination communication, again, not a part of attachment parenting per se. The fifth B I'll discuss is bonding, and the 6th B is belonging. So birth, breastfeeding, bed sharing, bowels, bonding, and belonging. Are we having fun yet? All right. So birth. What were some of the gossipy things that we generally were hearing, some of the supposed controversy? Some of the things that I think most prominently stand out was people really asking the question, what's wrong with C-sections? Why not C-sections? And people are still asking these questions, even though we have people who have been championing the cause for educating about C-sections and natural birth. I would often hear, what's with all these birth Nazis, making people want to love pain, right? I mean, that's what I would hear. It hurts. Why would you want to do anything that would hurt? And why should anyone tell me that I should have an experience that hurts? Isn't all birth equal? This is another thing we started hearing. Another sort of gossipy rumor is that elitist white middle and upper class women are ruling birth for their own selfish martyrdom needs. I've heard that more than once. And then, of course, all of the untruths about death rates, birth rates, all of these things, comparing things that should not be compared. Those were the main kind of, I felt like, controversial issues that the media was presenting about the birth controversy. In terms of the goodness that I feel like has come out of this discussion of birth, I feel like we've actually really placed out there, we really have placed into the public sphere how many is too many C-sections. What does it look like when we have a C-section rate that hovers around 30%? What does normal labor look like? A lot of people literally do not know. And I feel like this past year has shown a lot of people what normal birth looks like. Ricky Lake's documentary obviously catapulted the politics of birth and labor into the public eye. And I mention her because what she did is hopefully what we can do for all aspects of attachment parenting. Ricky was able to normalize birth, and Abby, they were able to normalize birth. They made it approachable. They even made it warm and fuzzy. I never looked as attractive as any of the women in her documentary giving birth, but that's okay. But I think more women are talking about, more women are demanding specialized labor and specialized birth environments. People are learning about birth plans. People are learning about their rights. People are finally learning. The people who didn't have this information before, I really feel like in the last year we've seen people understand more about the difference between C-sections and not C-sections. The second B, breastfeeding and extended breastfeeding. Some of the gossipy questions and gossipy accusations, does breast milk even matter? Really, what's the difference? Who are the breastfeeding Nazis? I won't mention the word Nazi again, but I hear it in terms of birth and I've heard it in terms of breastfeeding. Telling women what to do with their breasts. Does breastfeeding encourage an unrealistic and damaging lifestyle with the dependence on being home, being bored, and really breaking down everything that the feminist movement worked against? I'm sure many of you have heard, why would anyone nurse a child with teeth? Why would anyone nurse a child who can ask for it? Why would anyone nurse a child who can stand on a stool and breastfeed comfortably? I've heard the word gross, I've heard the word wrong, I've heard the word damaging, and I've heard worse. I've heard worse to my face on live television about what it is to breastfeed an older child. What's the goodness that comes out of it? I really do feel like in the last year, there has been really a normalization in some aspects of breastfeeding, and even of extended breastfeeding. I do feel like a lot of the discussion, and I'm being a public person, I'm not a huge advocate of celebrities leading the way for anything, but in our culture, it absolutely does make a very interesting point when celebrities post pictures of themselves proudly breastfeeding. Pink did it recently. Alanis Morissette came out and spoke about breastfeeding an older child. Again, unfortunately, it sometimes takes seeing those kind of images for a lot of people in our culture to really have access to it. And I feel like in addition, we've really had the opportunity in the last year to talk about not only the nutritional aspects of breastfeeding, but the immunological properties of breastfeeding, the psychological properties of breastfeeding, and really how breastfeeding is a family approach to parenting and also to discipline. The third B, bed sharing, and its tender sibling, co-sleeping. You know, what stands out to me the most is that city of Milwaukee and the ad with the butcher knife in the bed. And this is something I really did not speak about when it came out. I didn't really feel like I should have to answer to it. However, Nightline asked me live on camera and showed me the image and wanted my reaction. And obviously I had seen it before. Anyone on Facebook who's an attachment parent or has ever slept with a child probably saw that ad. My response was, don't sleep with a butcher knife in your bed. But, you know, obviously the other gossip, besides that it's as dangerous as sleeping with a butcher knife in your bed, claims of harming marriages and sex lives, claims of increasing postpartum depression, claims of increasing sleep deprivation, claims of being not only dangerous, but weird. And in terms of the goodness, again, I feel like there has been an opportunity to educate people about what safe co-sleeping is. And I realized very quickly during this book tour, I always use the word safe when I talked about either bed sharing or co-sleeping. And you know, I remember I was interviewed on a talk show in New York, and right before the segment went live, they told me, oh, you know, leave room on the couch for our doctor. I said, what doctor? They said, oh, he's a doctor that frequently gives kind of doctory opinions. I said, well, what kind of doctor is he? I mean, with all due respect, I have a PhD, I like my PhD, but I wanted to know, like, was I dealing with an OB or was he a psychiatrist? You know, they said he's a marriage and family therapist. I think he might have been a PhD in psychology, but that was and I was thinking, okay, hopefully I can handle this. And a lot of these questions live were about the damaging aspects of a parent wanting to sleep with their child more than the child wants to sleep with them, you know, or wanting to breastfeed their child more than the child wants to breastfeed. But again, I was able to sort of discuss that you know, safe co-sleeping exists, it's important to us, and that it's very easy, and people like Catherine Jetwell and James McKenna, they've made an absolute academic practice of teaching about the values and the benefits of co-sleeping, and I feel like that has gotten out there even more in this last year. In terms of bowels, this is the fourth, which again is not part of attachment parenting. You know, I did want to speak to this specifically again because Diaper-Free Baby is here and because there's other potty things out there that you can look at and have a good time with. The main, I was actually specifically attacked for practicing elimination communication by an MD who decided to, I almost don't want to say it because I don't want you to Google it and give him more hits, but the title of his post on a website was "Don't Listen to Blossom," which I don't care that he called me Blossom, like that's not my issue. But I do feel like it showed me how much people wanted to capitalize on, honestly, on this kind of gossipy aspect. Just for clarity's sake, elimination communication is not for everybody, I know that, but some of the kind of gossip about it is that it makes your children anxious and they will wet the bed and it's unnatural and it's that early potty training is damaging and it's dangerous. But I will say that hopefully, even though it's been kind of snipped up on every TV show I was asked about it, elimination communication is not potty training. It does not look like potty training in any of the ways that potty training looks like potty training. Again, it's not for everyone. It's a huge time commitment. But for many of us, it's a really, really beautiful way to be in touch with your child and to follow your own instincts and to really learn about your child and your relationship with your child. So I did want to mention that. In addition, placenta ingestion is sort of one of these satellite issues that, of course, is not about attachment parenting. I think January Jones, the actress, was, you know, practically publicly, you know, burnt at the placenta stake over admitting that she ingested her placenta. Just show of hands, curious? Anybody? Right on. Oh, that's great. Okay. So again, this is another issue that then blows up on all of these popular parenting sites, which honestly many of which are owned by the same popular magazines that really make their living out of gossiping about celebrities. So I really hope that people also are more careful about news outlets in seeing how people especially report attachment parenting. All right, number 5, bonding. So I already have mentioned this a little bit. The gossip that I've experienced and that I'm sure many of you have experienced regarding bonding is that attachment parenting is unhealthy. It's growing an unhealthy dependence. It's growing an unhealthy dependence on the mother. What I often hear is that there must be some psychic wounds in us that make us feel the need to repair our screwed up childhoods by really making our children need us as much as we need them to heal us. I've also heard, in this kind of relationship that you're creating, the child runs the house, the child calls all the shots, that the attempt to bond is really squeezing the life out of the mother and the father and the entire family. I'm sure you also hear, and I've heard a lot, babies need to self-soothe, babies need to be independent as soon as possible. The goodness, and this was actually a really hard one for me to identify what the goodness has been, because so much of this has been negative in places. I mean, every time I open the New York Times, there's some article about the criminal aspects of attachment parenting. Also, people like Elizabeth Batente, I mean, specifically with the breastfeeding issue, but also with this issue of larger bonding. I would hope that in this last year, there have been enough of us speaking out about it to show what bonding looks like cross-culturally, what the physiological and what the psychological aspects are of primate bonding. Of course, not everything that's evolutionary is good, but as a neuroscientist, I tend to believe that a lot of the hormones that are encouraged and facilitated by natural labor, by birth, by a natural birth process, by breastfeeding, by sleeping with your child, that kind of bonding is, I would argue, evolutionary beneficial. I think some of the other kind of goodness that's come out of it is a larger discussion of, I talk about it in the book, lowering your expectations. There was a Saturday Night Live sketch about a dating service for people who couldn't date anyone else, and it's called Lowered Expectations. But I do talk about that in the book, that if you no longer feel like what's normal is 10 hours of sleep, and you no longer expect to have a car for every child in your house by the time you're 16, and you no longer expect that you will be going out with the girls from the week after your baby's born, and you no longer expect that your life will be about a lot of luxury, excess money to go have romantic weekends with your husband. If you don't expect those things and you practice attachment parenting, you will not be disappointed. And I think in addition, some of the attacks on the mother-child relationship and that sort of, quote, unhealthy dependence, I really have tried to speak to, and other people have as well, kind of breaking down the women who say, I'm not good at this, I don't like playing blocks. Most grown women and men do not enjoy playing blocks. That's not the point of being with your child. Being home is not for everyone. Attachment parenting does not require that you be home. But again, I think lowering those expectations, sometimes you sit on the floor and you play blocks, and sometimes you go for a walk, sometimes you want to scream, and sometimes you think they'll never stop nursing. Sometimes that happens a week ago. But again, I think organizations and individuals are really trying to speak to this. And the final point is belonging. And by this I mean this sense of, and this came up especially with the Time magazine cover, this sense of us being this elitist community. Are you mom enough? Do you nurse as much as I do? Are you as good of a mom as me? I think also this notion that attachment parenting is cliquish and that we shun anyone who doesn't do one of the 6 or 7. The notion that you have to make your own shampoo or you're out of the attachment parenting club. I actually have to make a new batch when I get home. Again, this was a hard one to try and find the goodness out of because so much of it has really, really, personally, made me feel very beat down about what I do. It's very, very difficult. I'm grateful to live in a community where there are a lot of women. I've sought out a lot of women who do it like me. There's a lot of families who parent like we do. Parenting is absolutely hard no matter how you do it, but I think a lot of the attachment parenting philosophy does absolutely make you give a commitment to a different kind of work early on. And for a lot of people, it's not worth it or they don't want to, and I really feel like that's fine. But I feel like the goodness that's come out of it is unfortunately Mothering Magazine is not in print anymore, but places like Mothering, places like Holistic Moms Network, who are here today, Attachment Parenting International, again, the Leche League International, which is not just about breastfeeding. The desire of and the compulsion, really, of the media to sensationalize anything that goes against the status quo, I really just feel like has been ultimately extremely unproductive. I feel like it's made our lives as parents more difficult in this past year because it's creating divides and it's introducing catchphrases, really, that are used by one mom against another. I also felt like a lot of what happened in this past year, really on all aspects, was, you know, if you've ever met someone who doesn't believe in breastfeeding, meaning they don't believe that anyone should breastfeed, it's the same as formula. There's people like this actually in my own family who I had to deal with very early on. What I found a lot of times is that the kind of dialogue where someone doesn't want to hear your side, I feel like that's happened for a lot of attachment parenting this year. So for example, you know, there's someone in my family in particular who really saw no benefits of breastfeeding, she didn't believe in it, she didn't breastfeed her kids, and they're fine. And I realized she didn't want to have a dialogue with me. She wanted to be right. She wanted to find places to point out, oh, are you sure he's hungry, right? And I finally realized she doesn't want a discussion, she wants to be right. And I feel like a lot of that has happened with attachment parenting. And I feel like it's something many of us have had to become a lot more sensitive to. When does someone want to have a discussion, and when do they want to be right? When do they want to tell you what their doctor told them? And I think it's okay also, we don't have to fight every battle like that. The goodness that I feel like that many of us can draw from this past year is honestly in being educated, in trying not to be defensive, trying not to be critical or judgmental or self-righteous, but also not being afraid to stand up for our choices and to tell what we do and why it works for us. Hiding behind whatever it is we feel we need to hide behind, whether it's untruths or half-truths or bathroom doors or dressing room doors, where sometimes I have breastfed in my early years. I really feel like being proud, being confident, and also being respectful of other people has been the key. My Leche League leader told me something very early on when I had my first son, who's almost 7. She said, what other people think of you is none of your business. And it's been one of the best things I've been told. Because however many nasty looks, weird looks I've gotten from nursing a 3-year-old on the New York City subway, yes, that happens, what other people think of me is really not my business. I get to do my best as a parent. There's nothing wrong with what we do when we make decisions that are educated and that come from a place of compassion. Thank you for listening, and I'm happy to take questions if people would to ask them. I'm being told I have 10 minutes to take questions. But someone needs to signal to me because I don't have a watch. Danielle will signal. I will repeat the question, so if you can't hear, I will make you be able to. Yes? Right. The question was, in terms of parents or moms who arrive late to attachment parenting, meaning they already have gone through birth and labor, presumably, are done breastfeeding, are probably out of potty training and all those other things. You know, one of the main principles, which I didn't mention, but I know has been spoken about today, one of the main principles of attachment parenting, as identified by Attachment Parenting International in particular, this notion of positive discipline and of gentle discipline is something that I feel you will find the most in common among parents who parent these ways. So in any particular group, for example, in this group today, there are women here who have had C-sections, who have had natural births. There are women here probably who have had scheduled C-sections or who have not. There's women here who have bottle-fed with formula. There's women here who have breastfed exclusively. There's people who've done a mix. There's probably people here who didn't want to or didn't like or didn't find it smart for them to sleep with their baby, and then there's people who still sleep with their kids. You'll find a vast variation in those things, but I have yet to meet someone who practices or believes in any of these things who also does not want to and who doesn't work towards the notions of never relying on force to handle children. So I think that's one of the things that you know, Adventures in Gentle Discipline is a fantastic book by Hilary Flowers. It's published by Bellies To Babies International. It's a great book about real moms with older kids especially, and how we deal with those things. To me, that's all an extension of what we're working towards. There's a tremendous variation in, as I said, the birth experience, the breastfeeding experience, but I think that's one of the things that will stay with us no matter what. I don't think you should go back to breastfeeding or sleeping with them if it doesn't work for you. But I think also it's important to point out that the components of attachment parenting in many cases are centered around educating yourself about pregnancy and birth and those kinds of things. So in that way, you may have gotten off easy, I don't know. Yes. I can hear you and I'll repeat it. Okay. This is a big question that probably doesn't have one general answer. The question was, how do you know when you're ready to stop breastfeeding? I'm a lactation educator counselor. I'm not an IBCLC. Those kinds of questions I think are best directed to a Leche League leader, to someone kind of who can talk more to your specific experience. But I think generally speaking, child-led weaning is something that works for some people. And the notion is not that the child dictates in general when you're done breastfeeding. The notion is that it does need to be mutually desirable. I like to say, in my experience with both of my boys, who I nursed for quite some time, I try to look at kind of how I feel in a week rather than a day. Because in the course of any given day, if there's molars, especially if the child is older, if there's molars, if there's a cold, if there's all those kinds of things, on any given day, I'm ready to never be a parent again, if that's an option. Like, can I check that box? Like, I'm done, I'm moving to Ziggy. But I think when I look at what it's like in a week, what is the relationship like? What does it still mean to the child? I am one of those people who does believe that children are done when they're done, but I also feel like it needs to be working for the mother as well, and also for the spouse. I don't believe that my husband gets a voice in when I stop breastfeeding, but I also feel like there is peace in the home, and there are discussions in the home that need to be respectful of the spouse. So I like to mention that as well. But I think also shifting your general notion of looking at kind of what a week looks like, looking at how much the child is nursing. Again, How Weaning Happens is a fantastic book, again, published by Leche League International, that discusses what kind of normal progression towards not breastfeeding looks like. And there's like a checklist. How easily distractible are they? Can you offer them other things? So there's gentle encouragement also of weaning that's separate from child-led weaning, but I hope that answered generally. Yes, ma'am. Sure, this would be the comedy portion of my talk. The question was, can you give us some ways to respond to people, specifically about breastfeeding or anything, because you'll get it about everything. Birth, okay. So this will work for most. Usually a deep breath, trying to have as pleasant a smile as possible. Thank you for your opinion. Thank you for sharing. This is working for us. If it's specifically about birth and birth stories, there's a great button outside, no negative birth stories. A lot of times, I think it's Dr. Sears who recommends, you can say that he's your pediatrician. Say, our pediatrician's okay with this, and thanks for your thoughts. You can also say things like, I'll look into that, thank you. You can also learn how to end a conversation. I'm uncomfortable talking about this, I'd like to talk about something else, and then come up with something else. Like I said, you'll get it about birth. With breastfeeding, you can kind of, there's more fun answers. Like, when's he going to be done? They can say, he usually does 2 minutes per side. So, before high school is a great answer. How long are your kids going to sleep in your bed? Hopefully before I walk them down the aisle. That's the plan. But I think generally, with my first, I would feel myself get hot. My heart would start pounding. I felt like it was my obligation to make someone agree with me. And like I said, I realized very early on, specifically with breastfeeding, there's some people who are not going to agree with me, and I kind of have to be okay with that. I think also organizations like Leche League International and Holistic Moms Network creates a community of people so you can learn from other moms how they respond to things like that. And in terms of EC, you know, just who knows how to respond, because I've tried everything. 2 more questions. One more. Danielle says, oh, running a tight ship. Yes, last question, and then I'm going to be in the red tent. I think there's an upgrade possibility if you really want to get closer. Last question. Uh-huh. Sure. So the question was specifically with how old is your baby, by the way? No. Who's to say? This lovely woman has a 5-month-old who is doing what babies normally do at 5 months, which is waking to feed, to be held, to, I don't know, say hello at 3 in the morning and not go back to sleep for 2 hours. The question was kind of specifically, what do you say about this kind of sleeping through the night obsession, honestly, that our culture has? One thing is, you know, I've learned who to tell information to, meaning that's not to say that you keep things secret, but you're allowed to be selective with who you complain to. You will know which girlfriends and which male friends or whoever you can talk to about how you're ready to tear your hair out and move to Tahiti. So I think that's part of it, is really controlling the kind of information. But one of the first things people love to ask is she sleeping through the night? One answer that our pediatrician, Dr. Gordon, gives, or has suggested people give, is yes. If they ask more, you can say, she wakes up 6 times, but she sleeps through the night, right? It's a lot about your shift and your perspective. And you can also say, not yet, but that's not a priority for me right now. You can say, not yet, but it's working for us. You can say, I've decided to stay up all night. That's our solution. But again, I think really being selective and knowing that this too shall pass. It will all pass. Everybody makes individual decisions about what they need to or want to do with this situation in particular. I did not night wean my first. I night weaned my second at 3, and he was still nursing 4 to 6 times. So you know, it was more traumatic for me than him, I think, with anticipation. But there is nothing wrong. And again, I think also reading up on some of the Detwiller stuff and some of the McKenna stuff will also give you a little bit more information for yourself about why it is evolutionarily beneficial for you guys to be up at night, and it will not last forever. Thank you all. Thank you for being here. Thank you, Bellies to Babies, and thank you.
Thank you so much, Dr. Bialik. So just a couple announcements on behalf of Bellies to Babies. If you are a red tent ticket holder, after this lets out, you can make your way over to the red tent, which is in the far back corner of the hotel. And a line's going to form there. We're going to have the opportunity to go inside, have a vegan catered meal, sit with our celebrity guests, and probably 5 to 10 people will be chosen to share their birth stories. There will also be some belly dancing and some special performances. I believe, last I checked, that there are about 10 more tickets to that. If you'd like to upgrade your ticket, then just go up to the front counter. Also, the silent auction, which is in the Piedmont room, straight back here, is ending at 4. And we will be announcing the winners, which you must be here in order to win, between 4:40 and 4:50 when we come back in for our next guests. I think that's everything I need to tell you guys. Thank you so much for being here today. And we have massage therapy and all sorts of funness to continue enjoying. Thank you.
are done.
But now we can know some of the other stuff that you're practicing. You won't go, aren't you going to beat that baby down?
Most of these things, the principles behind them are applicable far beyond. You know, and I get a lot of women. She likes just empty cups.
How about this one? Okay. I'm going to announce the winners of our silent auction. I have all of the tickets here with me. So if you hear your name called, when I leave this podium, you want to meet me at front registration to pay for your item. And then once you've paid, I'm going to give you the sheet. And then you can go to the room and pick up the item that you want. So don't bother going up to registration until I leave because we don't have copies and I've got it all right here. Okay. The winner of the purple Moby wrap is Hannah Davis. Hannah Davis won the purple Moby wrap. The winner of the teal Moby wrap and blanket, Sandra Morris. Sandra Morris, you won the teal Moby wrap and blanket. The winner of the navy blue koi Moby wrap and blanket is also Sandra Morris. Congratulations, Sandra Morris. All right, the winner of the Whole Foods cleaning basket is Derek Denzer. Derek Denzer is the winner of the Whole Foods cleaning basket. The winner of the Nurture Me organic baby food basket is Katie Go. The winner of the Trader Joe's Mama goodie bag is Christina Kalmbach, or Kalmbach. Christina Kalmbach, you are the winner of the Trader Joe's Mama goodies bag. The Tippy Toe Bunny and Goodnight Atlanta book, the winner of that is Emily Beard. Emily Beard, you were the winner of the Tippy Toe Bunny and Goodnight ATL book. The winner of the Beyond the Sling audiobook is Stephanie, I'm afraid I'm going to mispronounce her last name, Bangulian? Stephanie Bangulian. Bangulian. The winner of the Summer of Pier 1 Ginger Peach Spa Basket is Patty Lewis. Patty Lewis, you won the Summer of Pier 1 Ginger Peach Spa Basket. All right, the Pregnancy Massage Center gift certificate, that winner is Vindia Bott. Vindia Bott, you are the Pregnancy Massage Center gift certificate winner, and I'm sorry if I mispronounced. All right, the winner of the Mommy Pendant is Jared Monroe. Jared Monroe, you have won the Mommy Pendant. The Accessories by Allie necklace was won by Barbara Nicholson. Barbara Nicholson is the winner of Accessories by Allie necklace. Summer of Pier 1 Lavender Spa Basket, that winner is Peggy Crane. Peggy Crane, you have won the Summer of Pier 1 Lavender Spa Basket. Okay, the Garden of Life Vitamin Basket, our winner is Joy Ermita. Joy Ermita, you are the winner of the Garden of Life Vitamin Basket. Okay, our It Works gift basket and body wrap, our winner is Sarah Ray. Sarah Ray, you have won the It Works gift basket and body wrap. Okay, our McLaren Quest stroller, that winner is Mindy Pure. I think that's how you say that. Mindy Pure, you're the winner of the McLaren Quest stroller. Okay, that's everything. If you heard your name, please meet us at registration so you can pay for your item and we can get that all taken care of hopefully the next few minutes before I leave. Thank you so much.
You're exhausting.
I'll follow you.
It's just too beautiful to miss.
Okay, I have my roller Hershey bag from that it's hazel. It starts with water bottle. Hazel starts with and it's and like that. I'm gonna go like, okay, the worst feeling in the world. We're supposed to like friends now. But you could the midnight.
we can have everyone seated and strollers, if they can be parked outside, please, to keep it more open in here. So if all of the midwives who are in here can move up a little bit more, closer to the front, and we're going to get started in just a moment. There's still a few people coming in. Okay, everyone's working their way in. Okay, so next we're going to introduce Deborah Flowers from the farm. She's a longtime midwife on the farm, and she is a member at large for Midwife International, our beneficiary today. And she's going to come up and talk about Midwife International, and I hope you enjoy it as much as I do. What these women are doing, it's just amazing. Please welcome Deborah Flowers.
I want to thank each of you for coming today to support Midwife International. I also want to thank our special guests, Ina May, Maya, and Kinsey. I especially want to thank the women from Bellies to Babies for all the hard work that they have done. Karina, Katie, Joe, and Danielle. Would you guys stand up? Without all their hard work, this event would not have been possible. I'm proud to be part of this project, Midwife International, because I believe that the world needs more midwives. In the year 2000, I had the opportunity to go to Bellies to work with a group of Mayan women to teach midwifery skills. And I got to see firsthand that trainings of these kind save lives. In the very first week of classes that we had, I had one of the women come up to me to tell me about a woman in her neighboring village who was pregnant with her 9th child, and she had correctly diagnosed that she had symptoms of preeclampsia. We were able to go to this woman's village. The rainy season was starting, and people didn't have a lot of transportation options available to them. There was a bus that went about 3 times a week to that village. And as you know, you can't always plan to have your baby when your bus is running. The rainy season had started and the roads were flooding, and there was a very good chance that when she went into labor that she would not be able to make it. And because of her symptoms of a high-risk pregnancy, we decided to go ahead and transport her to the local hospital. And it's very possible that we saved the mother and the baby's lives. I went on to watch the students making decisions to transport women when it was needed. One of the students, the first 2 babies she delivered were in the breech position. And I had taught how to deliver a breech baby because I knew that they would be called to the deliveries where there were complications, and that they needed to have those skills. A lot of these women had a 2nd grade education. Many of them couldn't read or write, but they were very good with their hands, and they had very good memories. When I went back a year later, I was amazed at how much they had retained of what we had covered in class. So, since a picture is worth 1,000 words, I'm going to show little video slideshow about Midwife International and why I'm proud to be a part of this project.
Around the world, every day, approximately 1,000 women die while pregnant or giving birth. An estimated 8 million more suffer serious illnesses and lifelong disabilities due to complications at the time of childbirth. Every year, up to 2 million newborns die within the first 24 hours of life. Millions more suffer birth traumas that impair their development and future productivity. But the crisis does not stop there. In countries where women have access to care, few have the opportunity to experience normal childbirth. Western medical approaches to childbirth have sent healthcare costs skyrocketing without improving health outcomes. But there is a solution. One of the clearest and most compelling answers to this collective crisis is to train more midwives. When midwives are adequately trained and can work with the support of healthcare systems in their countries, they have the potential to make powerful changes for their entire community. The midwife honors the mother's process and is well prepared to recognize when transport to an emergency medical facility is necessary. There is an urgent need to increase the number of well-trained midwives who take a holistic approach to maternal health care, putting the woman at the center of all decision-making. Midwife International was established to bring midwifery care to women throughout the world through birthing centers that serve as living examples of the role of midwives and their special relationship to mothers and babies. Midwife International is committed to excellence in midwifery education, incorporating leadership and service, combining hands-on training with academic study in underserved regions where the need for midwives is great. Midwife International is establishing a one-year training program that provides student midwives with hands-on experience and education that meets the standards of the North American Registry of Midwives. Midwife International students will be placed at birth clinics around the world, made possible through partnership with organizations such as Mother Health International. The tuition fees paid by student midwives will provide financial stability for the birth centers and a solid business model that can be replicated in other locations. Midwife International is opening a new birth center on the shores of Lake Petit Juan in Guatemala, providing access to the midwife model of care for the mothers and babies of that region. The birth center will also be the clinical site for Midwife International's 3-year program that will train both local client women and international students as professional and licensed midwives. In addition to the funds needed to open, Midwife International is also seeking additional midwives to serve as preceptors and educators at its clinics and birth centers. Student applications are now being accepted for the 1-year program. A safe and healthy birth should be the right of all women and babies. Midwives provide a service that is a unique bond of both mother and medical professional that embodies compassion and technical expertise. Your contribution to Midwife International can have a direct impact on the lives of women, children, and families around the world. The birthing centers and school to be established by Midwife International are like ripples on the water, reaching far beyond to touch the lives of countless women and children. The goal to establish a model of care that can be repeated again and again is within reach. your support, this vision of care will grow and achieve its potential and make a difference.
Thank you.
So now we want to call up Viva and the Flying Penguins vocalist, and she'll have some friends joining her today, and they're going to be performing a song that is dedicated not only to midwives, but I'm Meg Gaskin, the mother of midwifery. The song is about the ocean, and it's a beautiful song, and it's called So Magnificent, and it's talking about being near the ocean, which is symbolic for the feminine energy, like the baby and the amniotic fluid, and there's just a lot of symbolism about the unity of women and midwifery, and so it's basically giving women midwives a very high praise, honoring them for what they do and all that they do. So Aviva's going to come up now. Welcome, Aviva. Aviva just won the Atlanta Jewish Music Festival Award for songwriting.
Hi, I'm not Anna McGaskin, as you can tell. I'm Kim Story. I'm one of the nurse midwives at Atlanta Midwifery. On behalf of all of us, we'd like to welcome you here today, and thanks for coming and sharing this day with us. At Atlanta Midwifery, it's a collaborative agreement between all midwives at North Fulton Hospital, which, as shown in the slide earlier, has the lowest C-section rate in the city. And we work well together. And the reason I'm here today is to introduce to you a new centering program that we're going to start in 2013. And centering pregnancy has been shown to decrease low birth weight babies, reduce preterm labor, and moms and babies have better outcomes. And we're going to be starting our first group in 2013. So if you have any questions, please call or look on our website, Atlanta Midwifery. And I didn't know I was introducing Anna McGaskin until a few minutes ago, so I'm a little nervous. Because when I was a student nurse, I read her book, Spiritual Midwifery. From then on, I was hooked. And she is just one of my role models. I'm just so nervous. I'm going to forget everything I wanted to say about her, but she is truly leading a movement out there for all midwives and all moms wanting natural childbirth and decreasing maternity and morbidity outcomes in moms and babies. And with that, I give you Anna McGaskin.
Little duct tape rearrangement here. Well, thank you all for creating, everybody that had a part in creating this wonderful event. It's events like these that are actually going to help change the world. None of us can do it alone. It's going to take every one of us who is aware of how much birth matters. And thanks to everybody who had a part in organizing this. Special thanks to Doug and Deborah for getting me down here. I got a lot of writing done in the back of the van. And I thought, why don't I do this all the time? It's much faster than being at home. Some of you probably have never heard of Professor G.J. Klosterman. Raise your hand if you've heard of Professor Klosterman. See, some of us are old enough to remember him. I've actually touched him and spoken with him. He was really, I would say, the father of sort of the Dutch system, or one of the fathers, because there were grandfathers as well. We're so different here in the United States from the Netherlands. And you probably heard this endlessly, they still have babies at home, they're very stubborn people, why are they that way? And then, well, it had something to do, it had something to do with some special doctors back when. One was Hendrik van Deventer. I guess some of it was that his wife is a midwife, and so they did some pillow talk, and she told him how it worked, and he told her how it worked, and they, kind of got together on that. So anyway, here's Klosterman. I just want to read something, because I found this back in my bookshelves, and I found it really interesting. You might too. He passed away probably around 1990 or so, but it's worth knowing about it. He says, a consequence of male interest and curiosity surrounding pregnancy and delivery is the development of obstetrics and its tendency in many cultures to discount the role of midwives. A good obstetrician, traditionally male, and a good midwife, traditionally female, approach birth from markedly different perspectives. Obstetricians direct their attention toward detecting and treating pathological problems, whereas midwives take great pride in watching the course of a normal delivery in which the woman in labor maintains authority for the birth and does the work by herself. People can become meddlesome and overstep boundaries when a subject fascinates them. The desire to direct the delivery, taking power for giving birth away from the woman, and thus granting themselves the honor of bringing forth new life, can be very strong for obstetricians. But what a wise man to be sort of at that balance point and to actually know that we have a need for obstetricians and we have an equal need for midwives. And the interesting thing that I always found about the Dutch system was that the numbers wouldn't be equal though. You would have more midwives than obstetricians. You would have about 70% of all births would have the midwife only in the room. And the Dutch obstetricians in Klosterman's time, and this is like the 50s, the 40s, the 50s, the 60s, the 70s, they knew that you could actually trust the midwife to know when the obstetrician was needed. And that it was, you could actually trust us to do that. Now I want to tell you something about when I discovered that we needed midwives. Of course, I'm in a country with the opposite extreme because I grew up, even though my great-grandmother had been a midwife, I didn't know about it. I didn't get the stories from her. She was long gone before I appeared. And I wouldn't even have known what a midwife was if you'd asked me when I was 10, or even when I was 16 when I read Childbirth Without Fear, which was written by an obstetrician. And he told me that the main problem with birth is fear. And that if you didn't want pain in birth, you shouldn't be scared. And then he wrote a lot of other stuff that made a lot of sense to me. And I thought, okay, I could do that. And then I went and asked my mother, do I have to be afraid of birth? And she said, no. She said, a lot of people yell and scream, but it's really not necessary. And that took care of my curiosity about it. Then, oh, and by the way, my dad had been a farmer. And so I always had from him this yearning for being on the land because they lost a farm in the Depression, and he grew up in town, and so I think I got that from him. So I used to go summers, especially the summer when I was 9, and my cousins that grew up on the farm thought I was stupid because I didn't know much about the farm and animals and stuff like that. So I really listened up anytime I heard people talking farm stuff because I didn't want to be stupid. And from them I learned that, everything can be born. So then I had, in the university, was going to be, at first I was going to be an engineer, but then I dropped that because I couldn't get a scholarship, although my grades were good, but female was not the way to get a scholarship in engineering in 1958, 59. So I went into English. And there I was in the university, and I had a next door neighbor, and she was pregnant, so I got to watch her whole pregnancy from next door. And she had a very interesting story because she was a little woman with a 6'5" husband and one of those bellies that you just go, how could this be possible? And so she was about 40 weeks pregnant, went to her obstetrician, and came home with a baby. This was for a prenatal visit, mind you. And I said, what happened? And she said, well, he thought he should do an examination because I was due. And the examination put me into labor. And in 20 minutes, the baby was out right there on the exam table. I couldn't even get my socks off. And I went, wow, she's as good as a horse. Because I knew horses could do it in 20 minutes. And so that was my confirmation that Grantley Dick Reed was right, that we are just as good as the other mammals. Anyway, time went on. And so let me get to my subject of why midwives, why we need more of us. Well, what happens is when you don't have enough midwives and midwifery is not strong, then you start to lose obstetrics. Let me explain. Things are shifting so much that they're not quite the same as they were in the 70s. I attended my first birth. I got to witness my first birth when I was on a caravan of buses, a lecture tour. Yes, we did things like that. And I volunteered to see a birth because I knew by then I wanted to be a midwife. And I didn't know there was such a thing as a nurse midwife or any sort of training. So I thought it seemed logical to me. If somebody gives you a chance to observe a birth, you should go there. And so my husband was actually invited to the birth because he was a war veteran. And this was a woman who didn't want to go to the hospital because she tried that twice. And she had a bad experience each time. So I got to see the most wonderful birth that you could possibly see. A woman who was just happy that I was there, keeping calm. And I knew that was important because I'd had a birth in the hospital, and I knew that I would like to have calm people there, or nobody. And I'd been attended, I wouldn't even say attended, non-attended by a very cold nurse. And so I knew that warmth and tenderness was very important because if you don't feel that, then you don't want that person anywhere near you, let alone touching you, okay? So I just sort of did everything the opposite of what had been done to me in the hospital, and it worked. She had the baby very quickly, no blood, no tear. Baby knew just what to do. She knew exactly what to do, and I'd seen a miracle. So I never came down from that and couldn't obviously forget it. So if we have strong midwifery, then we have chances for it to work. Because we're just like other mammals. We need calm. If anybody's going to be near us when we're giving birth, which is kind of an earth-shaking thing to do, that's what it feels like, then you want calm around you. You don't want panic like we see so much on television, especially in dramatic shows, like Adrenaline, and panic and so forth. But you don't want that. So let me tell you what it's like in countries where you don't have any midwives. Because that was us in the United States from, we'll say 1930, pick your year, 1925, 1930, 1940 was when midwives started to be completely swept out of the picture. Well, then you had people like Dr. Joseph DeLee emerge, who he got his training, obviously not from midwives, because he actually wrote prolifically and I would say insanely about birth, because he compared women with salmon that die after spawning. Salmon. Now, he could have picked any kind of mammal, and he would have been better. And I used to be an English teacher. See, false analogies don't work for me. So at least pick a mammal if you're going to compare us with some other creature, because that was, the way I see it, there was a brief period there when doctors knew that babies actually could get out between women's legs. In the U.S., they thought you had to help them with forceps. And that was because we didn't have midwives. We could have known better. That had been different. There's a brilliant obstetrician, died some years ago, but he lived in northeastern Brazil. His name was Galba Aruja. And he knew that the experts in birth were the mostly illiterate parteras that lived in the jungles and along the river sides. And there's still maybe, nobody knows exactly, maybe 20, 30, 40,000 of them. But sadly, the World Health Organization does not recognize their skills, and because they don't have an academic degree, their wisdom is ignored. And yet, if we could just bring maybe 5 parteras up here with a translator and have them go into the maternity units, surely we could find a way to do it. They could show us how to do it. I was fortunate that I learned how to do breech birth because of the existence of a big Amish community in the place where we happened to settle and start our community. And Dr. John O. Williams, Jr., who was our mentor, Deborah and Douglas remembered him very well. We had a real serious love relationship with this man. He was also a Marine Corps veteran from Korea, as was Stephen, my husband. And so they hit it off because of that, even though Dr. Williams had been an officer and Stephen not. But Dr. Williams had a very soft spot for the Amish because they kept teaching him about obstetrics. And he was a family physician, just so you know. And he was the one who reached out to the Amish community going, they don't fit in, but they're worthy. You know, their religion, the tenets of their religion did not allow them to do it, to accept, let's say, Medicaid, because it's means tested. And so if they happen to live in Canada, they'd be okay with the Canadian healthcare plan because it's not means tested. Just to be a resident of Canada is enough, and you have your health insurance. So he reached out to them, and they educated him in birth because, as you probably know, they don't do birth control, and they do sex, and so, and this unusual group didn't do breastfeeding. That's unusual because most Amish would have done that. So that meant that their pregnancies were even closer than most Amish groups, and so a lot of women would have really a baby every year and a half, or some of the extraordinary ones, pretty much every year. And I think he was wondering how he was going to manage when we came along. And then I think he had a plan. Okay, we'll help the women of the farm. They seem to be quick learners. And God knows they need some help because if we had all started going to the hospital, we would have amassed a hospital bill that we would still be paying. Plus, we didn't have enough cars to get us there. So with his help, and that just meant he was available by the phone. He was very intuitive. He knew when he needed to come out and show us something. But most often it was just he was there to answer a question. And he got us through, so many births. Do you know what our data, our statistics were? Fortunately, I wrote it all down. But from that first birth I saw in the parking lot, and I just opened up the first edition of Spiritual Midwifery that was published in 1975, the last time I had a baby. When I was, I was expecting a baby as I was writing that book, and I was actually taking photographs while I was in labor with that baby, who's about to turn 37. I counted up the births. We had had 372, and we had 2 C-sections. Only 2 C-sections, and no deaths because of our low C-section rate, and no forceps. What does that tell you? I guess it would tell you the same thing it told me is, since we didn't ever turn anybody away from our community because the husband was too big, or he had too big a head, or mom looked too little, we just let everybody in. So we had a random sampling of American pelvises and a few Canadians among there, and that baby could get out without forceps. So when everybody tells me that they've been into a women's studies course or an anthropology course where they've learned, then you can learn this. You can go on, you can learn it on the, I put learn in quotes, on the internet, that the reason that we have trouble giving birth is because we have 2 legs. And supposedly that creates an inferior pelvis because nature's really wasn't a good engineer, a good designer in our case. And we have these enormous head, on the baby, and even though the scalp plates, skull plates will slide over each other, it's not enough. And, for the price of walking upright, we can't give birth. Then I go, so why does the baby get here on the highway, usually without any problem? And the truck drivers that, we're reading about the truck driver whose mama was a midwife and grandmother was a midwife who carries a birth kit because he's done 3 births in the last 13 years of people that couldn't get there. And I go, well, there's an argument for midwives because we midwives are actually fairly good at knowing when we've got a woman like that in our care. Even if it's a first baby, we get to where you miss a birth or 2 and you can kind of tell who those women are. And what you do with them is you try to get them next door to you. Am I right? I have seen 20-minute labors in first-time mothers. It happens. Okay, so let me just talk to you a little bit more about what happens when you don't have midwives. And believe me, you can actually now have countries where they have people who are called midwives who aren't. What do I mean by that? The midwives, in quotes, who got their training that aren't allowed to do any prenatal care at all because the obstetricians say they can't. That's Croatia. There's a lot of countries like that. Most of them in the formerly Soviet bloc countries. So in Croatia, which is a fine, fine country in many, many ways, and so safe in the cities that I saw 8- and 9-year-old girls walking home after their piano or ballet lessons unescorted by their parents, apparently safe. Can you imagine that, a country that's safe? At the same time, it's not very safe for birthing women because you have to see an obstetrician for every prenatal visit, and you're going to have a very rough exam, and you're going to have lots of ultrasounds. And then when you're in labor, they'll tend to pry your cervix open with your fingers. And then when it's pushing time, they don't really believe in the woman's body's ability to push, so they'll apply really a lot of fundal pressure. This goes on in Hungary, Romania, Bulgaria. The list is long. Because the midwives there in those countries were all really pretty much demoted to what we would call, maternity nurse without much leeway. Because, hey, there are a lot of maternity nurses that were actually midwives, actually caught the babies when the doctor didn't get there. And there may not be any in the room now, but I can guarantee there are a lot of people my age that would say, yeah, I'm one of those. Okay, so now here's what else happens. Croatia has many, many islands that are part of its population, and these are populated islands. Back in the day, people were born there. But when this fear of birth really took over and the obstetricians were the ones to make all of the rules, suddenly there were no midwives there. And the only way you can communicate with to get from the island to the mainland is by ferry. So when I learned that, I said, okay, so how many babies are born every year on the ferries? And they said, how did you know that this happens? And I said, it's obvious to me. You know, it will happen unless you get everybody out, there who's 6 months pregnant or more, you're going to have ferry births. Well, now if you have a midwife riding on the ferry, every ferry boat, that might work. But why not just put the midwife on the island, and then, you can have an obstetrician visit every week or two, and then, helicopter if you ever have a serious problem. And a lot of times your midwives, in working in situations like that, their intuition kicks in, and they'll know who to get out early. How do I know this? Because I went to Scotland right after Croatia, and that's what the Scots talk about. They too have lots of islands, and they have worse weather. I mean, cold and wind and high waves and so forth. And they boast about how they're going to get a midwife, no matter how remote the territory, how rugged the mountain path is to where these women insist on living because their ancestors always did live there, etc. So it can be done. I'm also reminded of Bangkok, Thailand, where, again, they thought, home birth, oh, how medieval, let's stop it. We're going to go to the hospital. We're going to be modern. We're going to be like the U.S. because we're the symbol of modern throughout the world. So they hadn't thought it through, though, because part of being modern was everybody got a car. And if you've ever been in Bangkok, you know that Bangkok was not made for cars. So guess where babies are born? In the traffic jam, in the cars, in the exhaust fumes. And they found it necessary to organize squads of what they called motorcycle midwives. They would have their birth kits, and then they would have their radios, and they would, weasel their way through all these crammed cars to get to the baby being born in the car. Again, wouldn't it make sense to have the midwife be in the neighborhood so that the women wouldn't have to go through all that nonsense? So here's what happened when I was in Croatia. I met some wonderful midwives. I met some wonderful obstetricians. And it's poignant to see them trying to be like us and see what that gets them. One woman was 6 months pregnant. She was still suffering from the PTSD of the kind of treatment that I just described to you in the first pregnancy. And they have an organization they call RODA, which is sort of, it's a play on the word stork, And it seems that the government has now tapped into their email communications, and so they can identify the women who are sort of flirting with the idea of maybe having a home birth. Because it seems that there's a very brazen Serbian midwife who just goes, okay, arrest me. I don't have any grandchildren that will miss me if I'm in prison, and I do this because I do this. Or there's an Austrian midwife that will go over the border and come in and help too. The police will visit you and try to intimidate you from having a home birth. And I'm going, okay, why does that sound familiar? I mean, we're not having police visiting yet, but I can't even count the number of midwives who, dedicated midwives, sit in jail cells, physicians who were run out of town. I've been hearing about this since the mid-'70s. We haven't stopped doing it yet. Some of the very best practitioners get treated the worst. And I do want to compliment North Fulton Hospital on its 20% C-section rate, because I know it takes some doing to do that it's a group effort, that some people will insult you and talk behind your back and ostracize you socially and attack you for being a baby killer ugly language, and so kudos. Keep doing it, and we'll try and help you all we can. You probably heard that Dutch midwifery is in some trouble, but don't count them out yet. I mean, there's still 22% home birth. I was telling them, don't be disconsolate about this. You can come back. Because, I mean, if we had 22% home birth, wouldn't we be flying high? I mean, we would think, wow, we can do it, you know? And I actually think we can achieve that. I can't tell you how long I've hoped for moms and dads to realize that we midwives, and certainly obstetricians, can't pull this off, and we can't make this happen without your help. And one of the small countries in the world is kind of leading the way with this. It's New Zealand. There was an amazing woman named Joan Donnelly I had the privilege to meet. And she was Canadian born, but she used to go to home birth starting in the early 70s, almost around the same time I did. And she was a trained midwife, and she started attending home births. She didn't have a home at the time. She just brought her sleeping bag from birth to birth. And so when she got the baby born, the baby was born, baby was latched on well, everything was cleaned up. Then she sat down and she started the parents' political education. And she said, it's about partnership. And we're going to run into a lot of opposition here because people don't think birth works anymore. People have become superstitious about birth, and they think the home is not a safe place, and we know better. So when somebody attacks us, we're going to go visit our members of parliament, and we're never going to have a midwife going alone. She's always going to go in with a woman whose birth she attended. And that was the magic formula. And that's one of the reasons that midwifery has made a very strong comeback in New Zealand, and women have the choice throughout the country whether they will give birth in hospital, in a birth center, and at home. So let me tell you something that you might not know. I mean, we all know what birth centers are, and they sound like a wonderful kind of middle ground for a lot of women. A lot of women that go, yeah, I wouldn't want to be in the hospital, but you know, I don't think I want to be at home either. Well, I've got news for you. The word birth center was never heard until there was home birth first. In fact, I first knew that there were nurse midwives after we started having a home birth movement, because that's what pulled those midwives, those nurse midwives that already existed, into getting jobs that involved them attending the birth, not just giving prenatal care or not just being part of creating more nurse midwives who couldn't get jobs. So home birth is very powerful as the choice that must always exist. Even if as few as 1% or 2% choose it, it's still very important. Let me explain why. Now, you've heard of the Gaston maneuver, and you probably know that I didn't invent it, right? I just wrote about it and spoke about it and put my name to it because I wanted people to be able to talk to me about it and find out what I'd written on the subject, find out what our data had been, and I also wanted them to know how I learned it. So let me tell you, we went to Guatemala in 1976 after the big earthquake, and as soon as I got off our bus, I met Etta Willis, who was a Belizean trained, and that's a British style of training midwife. And she was the district midwife, the supervising midwife of the parteras. Well, they actually were called comadronas in Guatemala. And these were the Highland Mayan women who were pressed into being midwives and who couldn't read. But that didn't mean that they didn't know what they were doing. She said they had a much better way of dealing with shoulder dystocia than she had been taught. And she had been taught the way I had. Fortunately, I never used it, but break the clavicle of the baby. And if you didn't do that, you could attempt to wrench the baby around and rotate it into an oblique diameter with the shoulders and see if you could get the baby that way. But she said what she learned from the Mayan midwives was just get the mother to roll over. Presumably she would be lying on her back or seated leaning back. Just get her to roll over and get on her hands and knees, and the baby would come. That's all she said. I didn't even ask a question. But a few months later, I was home, and we had birth number 2. Birth number 1 had been a 7-pound baby, and we were to find out that now we had a 10-pound baby. And his head was born. He wasn't coming. He was enormous. I had a doctor there because I knew this was a difficult birth. And he was kind of learning birth from us in some sense, although he had lots of skills that we learned from him too. And so when we had this stuck shoulders, I suddenly remembered what Etta had said. So I asked my friend to turn over, and guess what happened? Out came this enormous, wide-shouldered boy, over 10 pounds, intact perineum. And he breathed right away, and we were totally happy, and I told all my partners about it, and that was the method we used from that day on. And we've never had a birth injury, which is highly significant. And again, we were lucky enough to make a video in 1980, probably when Mary was born, around 1980 or 81, which is still available on my website, may.com. And it's been used around the world very much. So, okay, so we got that from home birth, right? I was shocked then when I was invited to speak at many medical schools, and then I got to learn that from residents, young residents, who would sit up in the front of the audience and look all excited when they would see these births, and they would say, "We have never seen a birth without an episiotomy. We are just amazed to see that a woman can do that." And so then I got letters back from them saying, "Well, my wife," this was from a young resident, said, "I was there when my wife gave birth the first time, and we did an INA." And I said, "What did you mean?" And he said, "No episiotomy, an intact perineum." Okay? My grandmother would find, who was also named Ina, would find that hard to talk about. That should probably be okay. Something else that we learned was that, there's so many things, but okay, how about postpartum care is necessary? Now, I know that sounds like obvious, but we don't act like it. And so when we have early discharge, okay, it's easy for those of you who are, say, under 40 to not know that women used to be compelled to stay in the hospital for 5 days postpartum, around from the mid-60s on for some years. And then, let's say 1940 or so, we stayed in for 10 days. Now, there are obviously lots of good reasons that we don't do that anymore, but what's been forgotten with early discharge, and I'm talking 48 hours, you know, if a woman is apparently healthy at 48 hours, out she goes, right? The woman with the very best insurance coverage. Now, that's true in lots and lots of countries, but do you know that we are the main one, and the only one that I can actually name, that doesn't have postpartum visits by a trained attendant to the woman's home? That has consequences that the Centers for Disease Control is not able to count. And what happens is, when you put that together with something that I've been tracking lately as the C-section rates going up, there are too many maternity wards and hospitals in this country where, when I ask what happens to the placenta right after it's pulled out, you know, immediately after a cesarean, I go, okay, so what happens? And they say, off to the lab. And I said, do they check it for completeness first? No. Why would you do that? Well, it might not be all the stuff might not be out there. Even a little bit of membrane left in a woman whose uterus is then sewed up and she's sent home in a couple, 3 days, can cause her death. People don't know this. You can have a late postpartum hemorrhage just from a little bit of placental material left in the uterus, and the woman may not know that that sick feeling that she has is because something's in there that shouldn't be in there, because she's post-operative and she's got a lot of aches and pains and so on. And probably she's not told that this can be a danger. If you are a single mom and you are at home, you could bleed to death in your sleep on day 8 or 9 or 10, and it's happened. And I know the women's names because they're on my quilt. And so sometimes I hear about the one in, Olathe, Kansas, or the one in Watertown, New York, where you're not found soon enough that the baby's life is even safe. The CDC does not pick up on these statistics, and I feel a tremendous responsibility to tell you about it, even though it's an ugly thing to have to tell you, because I'm the only keeper of this uncomfortable knowledge. I can tell you the same thing about Cytotec. I knew about 13 maternal deaths, and a couple of them included the death of the baby too. Why were these women induced in the first place? The idea, I know the intention was good. Oh, we're going to keep the baby from dying before her body decides to kick into labor. But what if the cure, the treatment, is more dangerous than waiting patiently for nature to do its thing? Because almost always it will. Especially if you're not frightening women and if you're giving them good support through pregnancy. You know what we do for induction? Sex, 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 okay? If they've got a sexual partner, we're saying, come on, have sex. 5 times a day, come on. And if you don't have one, well, maybe you could get out your Hitachi one, or maybe you could. And yes, that's what Ricky did give me, that people wonder about in that movie. I've never figured out what to do with it. So I'm going to have to ask. But the other thing we do is we ask people to go hike, like walk up hills and walk down hills. And another thing works really good, and I learned this from an obstetrician in Japan. The woman leans against a wall with a cloth, especially something that you would want polished. I'm going to show you. But I wouldn't say start with 300 times a day. Start with, what you can do, maybe 5, and then make the next day 10. And we had to learn to squat when I was in the Peace Corps, and I'm so glad I learned to squat because I still can. And it's really handy to be able to get up off the floor when you're my age. But it makes labors go faster. And in Japanese, you say, goro goro paku paku biku biku. And in English, that goes, don't veg out, don't pig out, and you won't freak out. So it's good for, just worry and just those fears that flow through your mind, especially when you watch Birth Story too much. Don't watch Birth Story. Watch. I mean, there's so many things that we could watch now that you couldn't do. So let's do more of that. So I recommend on YouTube The Dramatic Struggle for Life. How many have already seen it? Oh, not okay, good. So you're in for a treat. So The Dramatic Struggle for Life. And so there's a really big-headed baby being born because it's an elephant. And it's a hospital birth. I mean, elephant equivalent because it's a zoo, right? And so normally, this is an elephant in a very unnatural situation, but elephants kind of get their way just because of their size, and they kind of know that. And so she's so great, and you watch her, and her baby doesn't breathe at birth, and so she's pretty cool about it at first, and she does her elephant thing, which is, think about how would you resuscitate an elephant. I don't think I'll tell you. I think I want you to see it. So, And then there's another one that's also as good. It's called Chimp Birth Attica Zoo. Attica, Attica. And here you'll see a chimpanzee who's I think an experienced mother, and by the way, that isn't her man, that's her mama, who's doulaing her. And she finds a very effective posture for slowing down the birth. And, you know, I never tell people, push through the ring of fire. I think anybody who's had hemorrhoids and been constipated would never be told to push through the ring of fire. That's like, don't push, right? So anyway, she gets an intact gurney up and a very nice birth. I think you'd love that one too. And then some guy, actually, I don't know the URL for this one, but it's also YouTube. It's like some guy put up a video of his wife giving birth in the car by the highway and just picked up the camera, and it's lovely. They didn't tell us, you know, that he messed up the car or anything like that. But that, you can find some great things there. You'll also find some things that you don't want to see, so don't look at them. But just keep it to those three and watch them over and over, and I promise you, you can learn some wonderful things. You would learn from the elephant, for instance, that there's wisdom in there. And she didn't get it from a book, she didn't watch a video, she didn't take a class, nobody told her. Maybe she had seen it before, that's possible, but how long had she been in captivity? It's quite possible she'd always been in captivity and she'd never seen it before. So the point is that there's wisdom inside every woman if she could just find it. You know? And I think that's what doulas do. Doulas help women. Let's give doulas a hand, okay? So guess what else we learned? We learned because we put ourselves in this impossible, it sounds like an impossible situation. 270 hippies drive to Tennessee in school buses, find themselves some land. The guy sells, the farmer sells his 700 head of cattle, and so we're just there with the rattlesnakes, the copperheads, the whippoorwills and whatnot. Chiggers. We learned about chiggers, don't sit in the grass without protection. And then, amazingly, I mean, we didn't have real roads, we didn't have running water, we didn't have electricity, and yet we survived. And we were having babies like rabbits because we didn't do birth control for several years till one of us went and learned how to stop or slow it down. Okay, so, but we all breastfed. And it helped that I didn't know that people had problems with breastfeeding. That was just an amazing thing. And I had learned a couple things from my aunt who taught me that if the nipples or the teats don't look right, well, make them look right. And so I learned that with a little heifer that she had. Everybody knows what a heifer is? Raise your hand if you don't know what a heifer is. Okay, I'm going to tell you. A heifer is a young female cow, a virgin cow. And so in this particular, my aunt did hand milking. And so here I am studying, trying to catch up with my cousins. And so she puts this little heifer in the stall, you know, where she's eating the yummy stuff. And my aunt goes to work as if she's going to milk her. And she explained to me, notice that she has two teats that are shorter. They're half as long as they should be. And she says, I've got to fix this for her before she becomes pregnant, or she'll get mastitis all the time and she won't be a good milker. So that's how I learned that you can work with flesh. Okay, so the first time I had a woman who had inverted nipples, gorgeous breasts, but absolutely inverted nipples that you couldn't get to come out. And no baby could get his or her mouth around it, and I thought, okay, no electricity, no refrigeration, baby must breastfeed, what are we going to do? And I thought, well, I've got to bring them out some way. and I couldn't get a baby to do it. And, you know, if I'd been a Native American and I'd seen some of the old women, they would have said, get a puppy. But we didn't have any men around. So I went, well, I think the husband could do it. And so I told her that, and she looked, she was raised in New York City, nice Jewish family, and that was like not her thing. But I said, it's got to be your thing, because I mean, baby's going to need to eat, right? So it became their thing. And she was ready. Then I had the same situation with an Amish couple, and I thought, okay, now I'm really out of my cultural league here, because we actually were 24% Jewish, and so I knew I could do certain stuff with New Yorkers that, you know, I wasn't so sure about the Amish, and I thought, I can't tell an Amish to do this. So I just decided to tell him a story about a French physician who had written that he had the same solution that I did. He said, for seriously inverted nipples, frequent and repeated suction is the best remedy. This should be done daily by the husband or an intelligent serving maid. Yes. For want of either of the above, a large puppy wrapped in a blanket that, you know, keep its paws in check would do. And then when I got to Scotland, they said, well, we just use a toothless old woman. I thought, yes. So that's, I knew, you see, in the situation that we put ourselves in, that I was forced to think the way an indigenous person was. That's what we had to do. And then if it was something that that Dr. Williams knew about, I mean, I don't, you know, in our local hospital, nobody had breastfed, maybe ever, that came out of that hospital. So they didn't know it at all. They have a lactation consultant. And in the last year or two, they actually finally hired a nursing club. So we're making progress. So I don't know where I'm doing for time here. Let me just say something, though, about how I told you that obstetrics is losing it. And I know this because I talk to obstetricians all the time. And keep in mind that I was saved by an obstetrician after birth 3 because I met Louis LePere, who was just the dream obstetrician that I needed at that time, because my next birth was to be a baby with a cord wrapped 3 times around the neck. Remember, I have a master's degree in English and never, you know, set foot into a nursing course or even a first aid course. And so I was about to have this birth happen, but before it happened, Louis LePere came over to my bus one morning. He lived right next to the park where we were in Rhode Island, and he said, would you like a quick course in emergency childbirth measures? And you're an obstetrician and you're offering me this? Come in, let me make you some tea and get my friend. So he sat with us that morning and started with blood pressure. We went right through sterile technique. He gave me the sterile gloves. He gave me his Benson's Handbook of Obstetrics and Gynecology. And Pamela and I traded it back and forth. The next birth was cord around the neck, mom hemorrhaging, and baby needing resuscitation, and we could solve it all right there in our school bus with what Louis had taught us. So I have a very special spot in my heart for a midwife-loving obstetrician. And they set a high standard for me, too. And also then Dr. Williams being a family doc who did obstetrics. So in those days, you were expected to do breech delivery. Expected. You were expected to do Leopold's maneuvers. And for those of you who are not familiar with that term, that means putting your hands on the woman's belly and being able to tell what's coming first, which way the baby's lying, how big the baby is, and by the way, is she pregnant? Now, let me explain. One of the most fascinating things I found in that little book was 2, 3, 4 paragraphs about false pregnancy with the Latin term, pseudocyesis. And I went, wow, you mean the mind-body connection is so powerful that some women, if they think they're pregnant, their body kicks in with hormones and can fool you into thinking she's pregnant because she gets the big belly, she gets the swollen breast, her menses stop, all of this stuff happens, and she'll swear that she feels baby kicking. Well, I actually diagnosed one of those in my first year or two, and had to tell the woman, and we didn't have pregnancy tests in those days, so you had to do it with your hands. You didn't have ultrasound. And I said, it might be a false pregnancy because I'm not feeling anything, even though I get it that you're having all these symptoms, but looky here what it says in my little book. And I covered up the part that said she's probably psychotic. I knew she wasn't. I knew she wasn't, and she later had 3 real ones. Okay, so why do I bring this up? Well, I lurk on the OBGYN list. I used to post, but, I just got tired of, how we ride around on broomsticks. And, I got my broomstick right up there in my kitchen and everything. Those jokes get old. And so anyway, I read about a woman in Cape Fear, North Carolina, at a big medical center there, who they found out she had a false pregnancy only after she'd been opened up for a C-section. I went, okay, how? Come on. And so then there was a little bit of talk on there, and somebody went, impacted feces. And I thought, oh no, that's how it happened. Somebody, by ultrasound, saw poop and thought it was a baby, a pregnancy. And then at a later visit, when it didn't get a heartbeat, well, of course, it wouldn't. But then they diagnosed an intrauterine death. Now, back in the 70s, obstetric knowledge was such that if you had a failed pregnancy that hadn't, aborted yet, you'd wait. Because nature does take care. Nature knows when something's not happening, and there is very, very, very rare that it would be retained. So this woman's going to get she's going to get a period. However, they freaked out, and they went, oh my goodness, she's a walking coffin, how horrible, let's induce. Now, it just doesn't work, because that poop eventually would come out, and she's not going to go into labor no matter how many days you induce it. So then when the induction failed, and there were 7 different obstetricians involved in this, 5 of them residents, 2 of them fellows of the ACOG. Please. So they opened her up, and that's what happened. So I was then invited to do grand rounds at a big hospital in the East, and I had a nice meal with the head of OB, lovely woman, and I told that story, and then she said, staff members were on either side of the table, and she said, well, I'm almost embarrassed to tell you this, and I thought, oh my goodness, what did I step in now? And she said, well, I almost did a C-section 2 weeks ago. But to her credit, she checked first, and this woman was not indeed pregnant. But what she was embarrassed about was her residents had detected it. And I thought, how is that possible? So the next morning I got my answer, because I saw a big copy of 23rd edition of Williams Obstetrics, and I looked in the index, and it's not there. Pseudocyesis, false pregnancy, spurious pregnancy, imaginary pregnancy, fantasy pregnancy, it goes by all those names. It's no longer in the obstetrics textbook. And it wasn't in the first 4 issues of Gabby Simpson either. And then I heard about another one, a teenager in New York City who they found out false pregnancy only at C-section. So I'm going, now that is the most unnecessary C-section of all. And now we've got your obstetrics education is going to cost more than it ever has, and yet you're not going to learn in most places about breech birth. I get emails all the time from young docs that go, I want to learn about breech birth. I want to know all these skills. And I go, why don't we do the same thing the Europeans do, since we can't give everybody the live woman having the vaginal breech birth in the hospital? There's this thing called a mannequin. They call them a phantom, a big doll. We could do it. And so I want us to have obstetrics back at a high level again. I don't want us to just throw away the use of hands because we have the imaging technologies, because we know that they're only as good as the interpretation or the angle. You can sometimes think you see a penis and it's not really there, or misjudge the weight. We shouldn't get superstitious, is what I'm saying. And it's the same way I think I know just because we use the keyboard, our kids should still learn how to read and write cursive. So I've talked to you, I think, long enough, but just one more thing on my list. The divide and conquer strategy is always the way the more powerful group continues to rule. And I think that's what's going on with these so-called mommy wars, you know, where the New York Times and other major media outlets like to pit women against each other and create a fight when there wasn't one. But I don't think that all of us in the birth movement, I certainly don't want to pass judgment on women who go to hospitals. I was one. And some women should be in hospitals. And women who are super, super scared of being at home shouldn't be at home. Unless by accident, you know. That happens too, but not much. So we get so much from home birth. And if it wasn't for home birth, we wouldn't know that upright positions work better. We wouldn't know that all fours increases the size of the pelvis. There's so much that we wouldn't know. And that's actually the shoehorn that got the nurse midwives in the hospital. So the home birth movement is actually what drives change. It's our laboratory of innovation. Imagine if you or I was an obstetrician and I didn't want to break that baby's clavicle, and this was in the days when the Zavanelli maneuver ruled, where you were supposed to push, you know, once the baby's head was born, the shoulders were stuck, you were supposed to unrestitute the baby's head, push it, you know, rotate it 90 degrees, and then push the whole baby back into the uterus and do a C-section. And I talked to doctors who've done that with not good results, and wished I'd come by, you know, a couple weeks earlier. We got to have, you know, you couldn't just say very easily in a great big teaching hospital, oh, I think I'll turn the woman over on all fours. People would shout at you. You know, you'll get called on the carpet. I mean, in many hospitals, even if you have a good outcome and you do something unusual, you get chewed out. That's not a way to learn. So we have to know that sometimes our very best innovators, Ignaz Semmelweis is an example, looking up on the internet, get punished for it. You get to be a heretic, and it's not an easy thing to be a heretic. You'll have a lot of insults and a lot of, you know, hurtful things said about you. And we need to reverse that. So what my passion now is to get the good guys and gals together to know about each other and network so that in every corner of this vast country, each woman will have a choice whether she gives birth and gets good hospital care, a birth center, or home birth. We should have that choice wherever we are. And if we don't have that, then birth totalitarianism is ruling. And that's what we've got to be careful of, and we have to stop. So thanks for everything that you'll all do to bring midwifery back, to bring obstetrics back to the place it needs to be, which is in perfect balance. It's a dynamic thing that we midwives know we need our obstetricians. We love the heroic ones, and we stand behind you, and we want you to do the same for us. And then we all need doulas. Don't we need doulas? Okay. Thank you. I'm so glad I get to do some questions. 3 questions. I see one. Shout it out, please. Okay. I dream for the day when we have an insurance company ectomy. They, who let them make policy? And I have to fault the American College of OBGYN back when, probably in the early 70s, when they let that happen, because they let breech skills slip away. And then that affected the twins, the triplets. And then it dried up. I mean, people got chewed out. The people who should have been teaching were chewed out for teaching breech. So that's the insurance companies ruled. At that point, they put their neck on, I mean, their foot on the neck of the obstetricians and the family docs. So how do we get that foot off the neck? We get rid of them. Let them insure cars, flood insurance, house, fire insurance, stuff that insurance actually should be for. Because what's happening now is it's gone global. There used to be nonprofit insurance companies in Europe, and that's gone away now. And so countries like England, the UK, Germany, Australia, I mean, these countries where global insurance multinationals, they are pricing the premiums they say that home birth midwives must carry so high that home birth is now being swept away in several countries at a time, despite the really excellent statistics that they show. I see nothing to do about that except to say governments actually have to make that illegal. Nobody's supposed to make profit off of birth. It's like selling the air, which we know they would do if they could. Now, I'm not saying the insurance companies, but the air capitalists would do that. And we know that they do that with water, don't we? I mean, we know they're doing it with farmland. And women are the earth. So we've got to go back to that. Somehow, New Zealand managed to do it. They made it so that you can't do it until you insure everybody. See, so that's why I'm for single payer all the way. And, I'd like to see us get there in a year or two. And so, yes, I'm going to vote for Obama, but I'm going to do everything I can to help push it to where we get everybody insured, not just the 33 or something more. And then once you do that, then you can't sue anymore. And so what you have then is you have everybody covered. So yes, there will be medical errors. There will be, tragedies, but there will be care provided so that families aren't driven into bankruptcy or out of their homes or into living into their cars because they have these giant medical bills they can't pay. So I feel for people who have to live under a fear of getting sued all the time. It's a rotten system. It's one that we invented. It was a side effect of not insuring everybody. And no other country would have thought of it if we had thought of it first. And the rest of the world has imitated us, and just very few countries, like New Zealand being one, that didn't. I'd do away with direct consumer advertising for pharmaceutical companies too. Yes. That's right. That's right. Mm-hmm. Okay. Smell. Yeah. And bright red bleeding. There's a couple of things they can have that a lot of women don't know you're supposed to just take it easy, and their families, worse, don't know that. When you get home from the hospital, you're supposed to sit on the bed for 10 days. Not just those who are recovering from a C-section, but even if you had an intact perineum, painless vaginal birth, you're supposed to sit on the bed until you have to get up and go to the bathroom. People are supposed to bring you food and drinks. I mean, that's the way sane cultures deal with postpartum. 6 weeks of that. You're supposed to get, treated like a queen. Because you did something very big, and you're doing something very big by just sitting there, feeding that baby, and being in a sweet temper and feeling all that wonderful glow. And it radiates out through the house. But how can you do that if you're a single mom? How can you do that if you've got to go back to work next week to put food on the table? So we are all fragmented to a place where it's really, really hard on our moms and our babies. And our dads, by the way. The Dutch have a beautiful system for that. They have a specially trained nurse. She comes 10 days postpartum to your home, whether you gave birth in the hospital, the birth center, or at home, and you can have her for 8 hours, 5 hours, or 3 hours, whatever you need. She'll walk the dog, she'll wash the floor, she'll breakfast in bed, help the kids with their homework, the whole bit, and it's affordable for everybody. And the Dutch taxpayer finds that actually works out to keep people from going back into the hospital. It cuts down on postpartum depression, of course, on postpartum psychosis and suicides. It makes breastfeeding a lot easier. So the woman who's up too soon, she's going to bleed too much, and it'll probably be kind of bright red. But if she's really kind of wasted looking and wan and just shaky and drawn and sad looking, there might be something going on in there. And I think that women in pregnancy and their doula should find out what's the operating room or the delivery room protocol, because I can promise you that every licensed midwife in Georgia up to the time when, I don't know, did they get licensed when you had the grand midwives, but when you had those midwives that took care of rural people and were still working, some of them, right through the 50s, the 60s, and some of them maybe were born by then. They knew that all the biscuits were supposed to be in the pan, and that you weren't allowed to go away from a birth until everything came out. You couldn't have a space there, or you had to go get the doctor's help because you wasn't going to go in with your hand and clean it out. But that was the woman that maybe needed, a manual exploration or a D&C, because a life-threatening hemorrhage is not a painful way to die. And it can make infection too. So the trouble with breastfeeding where she's not producing milk because the hormones in that rotting matter inside of her, it actually prevents her ability to produce milk. So that's a warning sign. And then just a constant cramping. This would be different from incision pain. It's just a constant cramping and an icky feeling. Those would be your main symptoms. Thanks for asking that. And we also have to tell women, this is important too, women who've had C-section need to be told it's a lot more important than for them to get the whole routine about birth control. They need to know what the symptoms of pulmonary embolus are, of deep vein thrombosis. So a pain in the leg in a woman who's had a C-section is a real danger sign. She needs to go right to the ER. She needs to let her doctor know about that immediately because she could drop dead. And I've got a lot of women on the quilt that are there because of that. And again, I'm afraid that the CDC is not picking them up because our way of counting maternal death is so poor in this country, so poor. And I'd invite you to go to rememberthemothers.org and have a look at some of the stories from the Save Motherhood Quilt Project, because that's what the goal of it is, not to condemn any kind of birth, but to say, let us, knowing that we have a high and rising maternal death rate, let's count everybody. Let's really try to count everybody, and to do that, we have to do it right the same way. It should be a federal thing, not a states' rights thing, because that's the problem. And one more. Okay, there you go. You're a perinatologist? Good. Right. Right. How do we train more to stay midwifery? Or to stay in midwifery? Oh, wow. Very important question. Okay. Well, I can tell you that it's just extremely hard to go from not having any to reinventing it. You can get rid of midwifery so fast. You can lose it in 10, 20 years. And then here I am 40 years into trying to get it back. And we were so lucky. I mean, if we had landed in Alabama instead of Tennessee, I don't know if I would have had a Dr. Williams to work with. So we were protected by our numbers. And then we were also protected by the fact that I wrote everything down that we had incredible luck. And that we were poor. I mean, people don't necessarily think of poor being a protection, but poor makes you walk instead of drive the car. So that's exercise. We couldn't watch television and get scared. We didn't even have phones so that our relatives could call up and tell us horror stories. So we were so protected by being poor. And also we were smart enough to know how to eat. So we learned from George Washington Carver, you eat your soybeans, eat your peanuts, eat your sweet potatoes, eat your collard greens, and all that. So how do we get it back? I think we have to get the midwife-friendly docs together. We should have a conference where we could get you all into a room together and do some thinking together, because, and that will mean some women will be having babies that'll miss you for the time of the conference, but everybody I talk to feels so lonely with just being the only one. Or how do we put it together to where we could speak with a larger voice? I have some hope because Obstetrics and Gynecology, the Green Journal, in May 2011, published 3 important articles, and they weren't research articles at all. One was called An Obstetrician's Lament. The second one was Lament in Stereo, and the third one was An Obstetrician's Hope. The first 2 were by women that were saying, we understand why women are having unassisted birth, because we have relatives, we have girlfriends who should have been able to have that vaginal birth, but she had a breech presentation and nobody could turn it and all this stuff. And the one that wrote Obstetrician's Hope had been doing home birth as an obstetrician for 5 years, and he's saying, and I'm out of here. I'm going to go work for Doctors Without Borders. And I'm going, okay, well, I'm glad you got hope, but and I understand why you're doing that, because you probably burned out. But that tells me that we've got to stop the isolation, because I've known so many really wonderful, decent, tender-hearted obstetricians that don't have good collegial relationships too often and get run out of town or mistreated and all that. There's safety. There's more safety in numbers. And what that told me is that there's somebody on the editorial staff there at the Green Journal that's, for the first time, we saw some reflection. And so I would say, right. I would, maybe that's still open, and you could write of your frustrations. And if a bunch of you at all could do that, I notice, I don't have a subscription, but I find out, because I'm sure that we can turn this thing around, but it's really critical that we do it soon, because things are going down the tube too fast. And to me, this whole thing of, I published my article about false pregnancy no longer in Williams, in Birth Journal, so it is in the medical literature. So it would be really good if we got some comment on that, because why me? Why would I find it there and nobody who edited that book? I want to edit it. Do you think you all could help me become an editor for Williams? I mean, I would change, I'm a word person. I would take all the mechanical imagery out of it. Let some midwives help edit the obstetrics book so it wouldn't make us sound like a car. I mean, like a lemon. I mean, if we were going to sound like a car, it ought to be like a Mercedes-Benz, but not some old rattle trap that can't get the baby out as well as a chimp. I mean, and I learned when I was in Malaysia, they have a word for person that's called orang. And so an orangutan utan means forest. Orangutan is a forest person. I mean, Asians accept the relationship of us with other primates and don't count themselves as so superior. And to me, we do so much time parading around saying we're superior to every other mammal, except when it comes to giving birth. And I go, what is wrong with us? We are screwed up. And the tough thing is that we've been screwed up for centuries. And so I'm writing stuff now where I'm going back and finding a midwife who, this is an amazing story. She's the second European midwife to write a book about birth. She was German, and she was 20 years old, and she had a false pregnancy. And so her midwife in her village, this was in 70 years old, went, you're pregnant. And so then she went into labor, called the midwife, and the midwife was with her for 2 weeks, calling in 3 other midwives, and they all said, yeah, your baby's lying right. But by the second week, they started saying, you and your baby are both going to die. Well, thanks a lot. So her mother and her husband called in a midwife from another village that apparently put her hands on her and said, you know what, you're not pregnant. So this woman then went, shook her world, but she went, I'm sure she was glad to be alive, but she thought, why did that one know more than the other 4? So she went and she looked at the anatomy books that were in the academy there in Frankfurt, and she saw the pictures, and some other women that had been with her as she was in labor with that first baby called her to a birth of a woman who had been in labor for 2.5 days and said, the arm of the baby's hanging out, can you save the woman's life? So she went there, and now here's a woman who had never seen a birth of anything, just like me. And she went, that doesn't look right. They looked like the baby's dead because the arm was all discolored as it would be. So she bends the baby's arm, and she pushes on the elbow, pushes the baby back in. At some point, the baby goes and rights itself in the uterus, puts the head at the cervix, and is born alive. And now she became the midwife to call, and she became a specialist that did pictures in her book about difficult births, because she said, hey, that French woman, Louise Bourgeois, already covered a normal birth. Now here's the rest of what you need to know. See, so we need to know that. It isn't like it's magic because it comes from within walls. Because, I mean, look, the Frontier Nursing Service is an at-distance program. So we're already admitting by the existence of the Frontier Nursing Service that you don't get it all just from the hospital. And midwives, old midwives had a wealth of knowledge. I would point you to Mrs. Margaret Charles Smith, Listen to Me Good, for an amazing midwife who never had any education of any kind past age 10. And she was a master. I mean, she got an 18-pound stillbirth out of the mom, the mother living through it, diabetic, but she diagnosed that this was a death in utero with her hands, and the doctor that she told about it said, how do you know? And she says, because her belly was cold. It was cold. And he said, well, you can't know anything because you don't have good enough education. I go, oh, she could have birthed him. So that's what I mean. We've got to expand the perspective and look for the soft spots. So I'm saying Green Journal's a soft spot now. There's somebody on the editorial staff there who is, I think, worried that we're going to get to where Brazil is. And I don't know how you get back from where Brazil is. I was in a hospital where the C-section rate's 98%. And you don't need obstetricians anymore. You just get a surgeon. It's a very specialized kind of surgery. And they've lost it. And I watched a guy who was afraid to turn, a real nice guy, who was dedicated to doing home birth, but he had transverse lie. He wanted me to turn it, he wanted me to video, and I was uncomfortable with the woman because she's lying there on the floor and I couldn't speak Portuguese at that time. So I just kind of reached over to touch her to see maybe if it was really that way, and accidentally did a version before. So that's fear. That's terrible fear. And, you know, so I could talk all night about that. But I think the Green Journal is showing us a soft spot. If we could write some more laments or some prayers or some more hopes for folks that are staying around. You know, and I'm not faulting David Hayes for his decision because I think Doctors Without Borders is a really honorable and wonderful organization too. Everybody needs this. It's so important that we save midwifery and that we save obstetrics. So thanks for your question.